thank you all for your patience. I am Dr. Esther Peter. I am an education specialist at AWCAA, the African Women's Cancer Awareness Association. On behalf of the staff and volunteers and the entire team of AWCAA, I would like to express our profound appreciation to all those present in the house today for your patience. We were supposed to kick about exactly 8:30 a.m. It's almost 9 a.m. right now. So we do appreciate your patience. Thank you so much. We understand there is some construction out there, and maybe that's holding up all participants. We're hopeful that we'll have the whole fields before the end of the first presentation. But we're going to move right on. So we're going to start proper. Good morning, distinguished guests, healthcare professionals, partners, friends, and champions of hope. On behalf of the African Women's Cancer Awareness Association, AWCAA, it is my absolute honor and pleasure to welcome you all to this year's International Oncology Symposium, a gathering of minds, hearts, and hands committed to advancing the fight against cancer through knowledge, collaboration, and compassion. First, let me express our heartfelt thanks to all our vendors and partners who have supported this event and continue to walk this journey with us. Your presence here today is not just appreciated, it is powerful. In a very special way, we pause to honor and celebrate our visionary leader, whose compassion and courage planted a seed that has grown into this impactful movement. She is no other person than our founder and CEO, Dr. Ify. Thank you. In 2004, Dr. Ify had a vision, a bold one, to establish a nonprofit organization dedicated solely to providing care, education, and resources to cancer patients and their families, particularly in underserved African communities. And 20 years later, her vision is not just alive, it is thriving. Under her leadership, AWCAA has conducted over 3,000 mammogram screenings. It has helped detect tumors at various stages in over 300 individuals, educating more than 5,000 people on cancer awareness and prevention, providing ongoing patient navigation and advocacy services that continue to change lives daily. So today, we don't just gather and celebrate a legacy, we continue a mission, and we're prepared to be inspired and informed. As we proceed with today's program, I invite you all to listen with intent, engage with curiosity, and allow yourselves to be taken on a meaningful educational journey into the dynamic and ever-evolving world of oncology by our incredible lineup of speakers. Today, together, we are saving lives. Together, we are building a future free from fear, full of healing, and grounded in equity. Thank you, and welcome once again. I'm going to move right on to introduce our speaker. Thank you. So, moving right along, we have our very first speaker. She is Dr. Gladys Onojobi. Dr. Onojobi has over 40 decades of experience in internal medicine with specialization in hematology and oncology. She's worked at Howard University, West Virginia James and Shirley Bailey Regional Cancer Center, at Garrett Regional Medical Center, Maryland, and now as the CEO of TK Consultant and Awareness. Her areas of focus are managing the physical, emotional, and social effects of having cancer and going through treatments. She has combined experience and expertise from a career to provide specialized care and support, and assist in managing the long-term effects of treatments regarding cancer survivorship. Her practice as TK Consultant and Awareness integrates treatments in hematology, oncology, integrative medicine, aesthetics, acupuncture, yoga, and herbal medicine to provide first-class services to patients. Her interest in homeopathic medicine, as well as pain management and anesthesia, prepared her for managing the suffering of cancer patients and the complexity of the disease. Ladies and gentlemen, a round of applause for Dr. Onojobi. morning, everybody. It's my pleasure to be here today to present this complex topic to you, which is hematological malignancies in the US community and the role of nurses in terms of providing care for our patients. So, to get right to it, I'm going to start by talking about the agenda will be the epidemiology in the US community, the diagnosis, and I'm also going to talk about the treatment modality and the nursing care, and also to talk about the psychosocial impact of in the community. We'll also cover how the community can support the patients. So I'm going to talk about the different types of hematological cancers that we have. And it's going to be the understanding that this condition is crucial in the sense that when patients present, they actually present as if they were having an infection. And it's really bothersome because so many people are not aware of what to do. And everybody talks about leukemias and they talk about what they need to do. So when initially it's been diagnosed, most of the cases that we see are usually acute leukemias. So they either present as acute or chronic leukemias. The acute leukemias is actually due to the fact that there's dysregulation of the bone marrow where the cells are supposed to differentiate, they don't, and they present with all the stem cells that are supposed to be in the bone marrow to the periphery, and the patients will have fever, chills, and we have different bimodal presentation, the young and the old. So in terms of the definition and types, like I said, we have to understand, sorry about that. So we have the definition of leukemias. We have leukemias, lymphomas. Lymphomas actually affect the lymph nodes, and we have multiple myeloma, which is actually affecting some of the stem cells, which is called plasma cells, that is in the plasma, as in bone marrow as well. And so even though all of them are coming from the bone marrow, they have different characteristics. So why does this happen? It talks about the pathophysiology and the genetic factors. As you know, in the younger children, it could have been due to mutation in the bone marrow at a particular time. And so you have between the ages of like newborn to about 17 to 18 years of age, you have the acute leukemics, and they actually affecting the blast cells in the bone marrow that come out to the periphery. And also we have people who have gone through treatment. They could have acute leukemias as well over the years. That's why cancer treatment does not just stop at remission. You have to continue to do that. And this is where it's also a role where the community and the nurses play, apart from being the treatment physicians. So we also have the different types of treatment over the years that have evolved with technology. So we can have targeted therapy and personalized care, which is actually one of the things that we're advocating for, that patients not only get the treatment in the tertiary center, in the community center, as well as at home, so that from the very beginning, you can actually look at a patient, diagnose them, and target the treatment that they're going to get over the years. So what's the epidemiology in the United States? Most across the board, it's the same type of presentations that people have for the young, the old, and the only difference is that the environmental factors, apart from the genetic factors and the familial factors, sometimes it's seen in farmers. So areas in the United States that take a lot of do farming because of the pesticides that are sprayed, we know that over the years, they can also lead to malignancies. And usually in the older farmers, because they've been exposed to it for so many years, and when they present for treatment, they are old, their bone marrow is not working, and so we have the survival for them is really poor. But now in children, because theirs is genetic most times, you find out that with technology, they have evolved. The treatment are targeted to these mutations, and they can actually reverse the transformation that occurs in the chromosomes of kids. So when the disease was incidence about 23% of survival, it's gone down to 88%. You see this on TV all the time in St. Jude's, telling you that no child comes without having some form of treatment. That's research and technology. But when it comes to older adults, they have a lot of comorbidities. They have diabetes, heart failure, and everything else. And you can understand the farmers, not all of them are rich, that they live a good, healthy lifestyle. So the prognosis there for the older population is very poor. So prevalence and incidence with that, we say that the significant concern for us, therefore, is to find a way how we can change the dynamics. Now that we understand what the causative factors are, when we look, we know that screening would be an important factor in terms of treatment and prevention. Cancer is not restricted to anywhere, it's global. As you can see from the map, you can see it's everywhere, in Africa, in America, everywhere, and it's about the same pathophysiology that they have. So now that the patients have got these cancers, how do they present? Presentation is key to the role of the community, the parents, and the nurses, and everybody around. Because this child comes from school, they are sick, every day they have a flu, it doesn't get better, or they get better, they get back to school, they feel tired, they feel sick, and that's how they go down. By the time the primary care physician is aware that this child is having a flu that hasn't gone in 2 weeks, they do the blood, and it's not all the time that people look at that, but they will end up in the tertiary centers. So this is what I want to show you. Like, this is a sick patient, always sick. Well, as adults, they might say they don't want to go to work, but that's not the key. It just continues. But now that we have various diseases like COVID, patients have long COVID. So how do you differentiate what they have? So physical history is very important as to when they started and how they are progressing. So the key, I said, is that the patient is sick. All you need to do as part of the test for us hematologists is to look at the blood count. Everybody does blood count, but people don't really look at it. They just look at the global part of it and say they are anemic or something. So when we look at the peripheral blood smear, this is what we see. We see this is a normal cell, a normal peripheral smear with the white cells all mature, all differentiated and looking good. And that's what we see in the bone marrow. You see the bone marrow, those are immature cells. Now imagine the immature cells coming out into the periphery. That is an acute lymphocytic leukemia. One of the cells has differentiated. It did not differentiate, it's just coming out as blast into the periphery. And the bad thing about these cells is that they are so immature that they stick together. And that actually is the reason why a lot of them come back with headaches, dizziness, and there's nothing you can do to them that will make them feel better because the cells are so stuck together and it's so hard for the body to get oxygenation and things from that. So that's why acute leukemics are bad. Meanwhile, if it's chronic, the cells are already differentiated. If you look at the peripheral smear, you see that these cells are mature, but the difference in this is that it's slow and progressive. You have too many of them, they don't die. So those are the chronic leukemics. And then they do well for a very long time. Patients will tell you that I have leukemia, and my doctor is not doing anything about that. That's because they have chronic leukemics and chronic myeloid leukemia, but after a while, they transform back into acute. So that's why there's a difference between the way we manage the patients. So, diagnostic criteria, it's changed. In the old days, it used to be just looking at the smear, and then you can decide in your heart what you think you've seen. What I see and what somebody else sees might be different. That's why you used to, in those days, used to have a lot of diagnosis and a lot of treatment for the same disease, but the way we see it is different. So the French, American, and British got together to do the classification. When you look at the slides, what do you see? And after a while, they found out that it doesn't really work well that way.
Then the World Health Organization came, and then they looked at all the slides and they say, let's stain them more. And then if we stain them more, maybe we can get more story out of it. And then as technology improved, we now have the molecular testing, where we send the patient for flow and they look through it. You have fluorescein attached to this. The antibodies that the cells are producing are actually detected. So you know that even though you are looking at leukemic cells, they are different because they carry different markers. And based on the different markers, treatment are now being targeted to all these different cells that you have. And so you can also improve the patient's immunity to combat the cells. So technology has really improved the survival, like I told you, in kids from 23 to 88%, and they are working towards cure, total cure. All right, so this is the role, what we mean by the role of the biomarkers and imaging. When patients come, when the cells come out into the system, into the periphery, they can get embedded into the lymph nodes, they can get embedded into the brain, they can get embedded into different organs. So when you do the imaging, you realize that these are the cells that most of the time the acute leukemias also affect the brain. So sometimes when you think you have cured and you have treated the whole system, then you see them popping up in the brain, and that's why most of the time if they don't have any brain disease, we still go to do treatment for the brain itself and give them intrathecal in the CSF to kind of protect the spinal cord as well. So we have to do so many tests, and this is key because the nurses would encourage the patient to say, I'm doing so many tests, I'm so sick, I'm keep doing tests. It's important because if you don't get it right from the very beginning, you might end up having the wrong treatment, and that might decrease your survival. So the key role is that the nurses and the family get encouragement and help these kids. They miss school, they miss so many things. But now if they have a good community, they can come to school, go to the nearest hospital beside them, and they are integrated into the community as well. So the psychological part of the disease is minimized sometimes. So treatment and modality and nursing care, I have gone through that. The treatment for acute leukemics is so complex. As you can imagine, when you have a whole bone marrow cells come out into the periphery, there is nothing else to do. So we do what they call induction. We have to clear the burden of the disease first and then consolidate it so that it doesn't come back again. So during the induction period, people are so sick, they will have to go to the hospital, they have to get transfusion, you have to do so many things. At the same time, we have to do tests while we are waiting for the results. There's a particular acute leukemia called acute myeloid leukemia called prolymphocytic leukemia. That, after a while, degranulates. It produces a lot of histamine, and the patient will start bleeding. And they bleed into their brain, they bleed into everywhere else. But this is one of the curable disease. In the old days, it used to be deadly. But now, once you recognize it, just looking at the cells, you start treating the patient with ANTRA, which is tricinic acid. That stabilizes the mast cells, and it's curative as well. But the patient has to be on it for almost 2 years. Can you imagine somebody having treatment for 2 years? So that is one of the reasons why we are encouraging the community to get involved with the treatment of hematological malignancies. So we're going to go now to nursing intervention and education. Nurses have to educate the patient. They have to. Because they give up, and when they give up, their survival automatically diminishes. You can imagine a child who's not been going to school, seeing the sibling go to school, and the parents too will have to divide their time between the sick child and everything else, and all the things that come with it. So, but if they have a nurse, the supportive care that tells them, you're going to get better, this is what we need to do, the child will definitely associate with somebody who sees positivity in their disease. The parents don't understand it, but the nurses understand it, and they encourage the whole family and say, this is what you need to do. And so over a protracted period of time, when the patient starts getting better, everybody feels happy before the doctors get involved with that. I mean, the doctors just treat and the patients go home. When the patients go home, who are there to help them but you? Resources. As you know, Medicaid, Medicare, everything Medicare takes care of these diseases. We need, as I was talking to Ms. Kosa this morning, we're talking about the challenges that face us when it comes to insurance. There is nowhere a family can afford to care for a patient for 2 years. I mean, pay mortgage and pay everything. You need the support of the government, and you need the support of navigators to help us to be able to keep this treatment going so that you can get the survival. Patient can survive, but if they don't have the finances to do that, they're going to die. And that's why we have to be more compassionate, and we have to look for ways in which we need to do that. The only way, the main ways that we know is clinical trials now, to help us to do fundraising, like organizations like APA, you have to get involved. You can't sit back, because it could be anybody in your family. We talk about bone marrow transplant and all that. We need to support each other so that we can raise more money to be able to do more research and do clinical trials. So especially black folks like us, we don't get involved in trials at all. Why? Because we are very, I don't know if it's a mental thing or because we don't trust the system, but if we don't get involved, how do people like us know that with the dynamics, like I showed you, the molecular biology that they do, that ours is different from the Caucasians? How are we going to be able to target treatment if we don't find us in the trials? So that's where the community comes in, to encourage clinical trials and make sure that the treatment of hematological malignancies are excellent for us and for everybody else. So we need a holistic attitude towards this care. So in conclusion, I have tried to explain and to understand and to educate you about the challenges that we face, the diagnosis, because everybody cannot have COVID when they have hematological malignancies. You get well from COVID with some complications, but you definitely die from hematological malignancies if it's not well taken care of. Can you imagine a disease that can be cured, and then you have a patient with so many barriers that needs to be broken down for us to be able to improve the care that we get for the patient? So in conclusion, we have to work together as a team. Thank you very much. Question?
Thank you so much, Dr. Onojebi. My question, just like you had rightly mentioned, is how do we get us, the Black population, especially the immigrant population, to be involved in clinical trials? Because the results of things like this actually helps to tailor the treatment to that particular population. If you have any answer or benefits to that.
I do. When a patient is getting treatment, we always offer clinical trials, always offer in every disease, because if you go to what our association uses, which is called the NCCN guidelines, it says that you have to encourage patients to go into clinical trials. But we are, as a population, as a group, as a people, are very skeptical about that. And I think it's a generational thing, but now we have to explain to them. That's why I'm saying that the role of the nurses and the nursing navigators is so key. When they have trust you go to them and say, did they offer you clinical trials? They say no. Ask about clinical trials. They bring all the papers to you. We go through it with them and say, this is not the right time for you to have clinical trials because they have a treatment that works. But when they are targeting that clinical trials to you, if you don't match it and you have to go to something else, why don't you try clinical trials? And if you don't get it, you can call. We have, although we are few, we have providers all over the United States that you can just take a phone call and say, I need to talk to you about this patient. Would they fit into clinical trials? Could you help us? We have to call. We have to be proactive. Or else we just sit down there and sit down there. Thank you.
That was all from Dr. Najabi. We'll have to call you back to the podium if you don't mind. We have something little for you.
So, most of the professionals here just left whatever they had to do to be here, to educate us, enlighten us, so we can do better. They say if you know better, you do better. So we like a little token of appreciation to Dr. Onajobi for coming out here to be with us. So this is for you. Thank you very,
Thank you
very
so
much.
much. Appreciate that. Thank you. Thank you.
That was awesome. Thank you so much. Moving right on. All right, so while we get this connected, I will be introducing our next speaker. She is a registered nurse. Her name is Miss Glenda Kose. Glenda Kose's role as a certified oncology nurse at the Washington Hospital Center in Washington, D.C. since 1991 has been a true labor of love. Prior to this, Kose held various other nursing positions, including a floor nurse on the surgical unit at the Hospital of University of Pennsylvania and an operating room nurse at Temple University Hospital. A native of Philadelphia, her desire to travel and help others inspired her position as a travel nurse, where she worked at Sinai Hospital in Baltimore, Washington Hospital Center, and St. Joseph Hospital in Burbank, California. While traveling, Ms. Kose had an opportunity to work on the inpatient oncology unit at the Washington Hospital Center, where she realized her passion and calling. She had then transferred to the outpatient oncology unit at the same hospital and worked as a staff nurse in the ambulatory infusion center until 2016. She has established a cancer support ministry at the Greater Mount Calvary Holy Church in Washington, D.C. She has been recognized numerous times for her commitment and dedication to those whose lives have been impacted by cancer. Ms. Glenda was named 2006 Woman of the Year by her church. In 2007, she was honored as Woman of the Year by the Celebration Life Foundation and recognized for her outstanding community service by Zeta Phi Beta Sorority, Inc., for which she is a member. The mission of this organization is to provide a one-stop resource facility for adults, individuals affected by cancer, and the support system. She is a graduate of Indiana University of Pennsylvania. Kose holds the Bachelor of Science in Nursing degree. Ladies and gentlemen, please put your hands together as we welcome Ms. Glenda.
just hit that. Okay. Well, good morning, everyone. Happy Saturday, and I just want to thank this organization for this opportunity to present and be a part of the symposium. I don't take these opportunities for granted. So again, I just want to say thank you. So I will be speaking on breast cancer navigation in a day in the life of a navigator. What do we do? A lot of our people think that we are super nurses. I know my providers swear that I walk on water. Who recognized the dog in the middle? That's Max from How the Grinch Stole Christmas. He's just supposed to be a dog, but remember, he put the antlers on him. He functioned as the reindeer, and then little Cindy Lou Who. He had to take all of her gifts from the house. So he did more than just what a dog does. So when patients always ask me, what is it that we do? I always like to refer to Max. And then again, super nurse. Okay. We put these readers on. Our learning objectives for today: to explain the origin and history of oncology nurse navigation, recognize the role of breast oncology nurse navigation, addressing and identifying barriers to health care, optimizing care coordination, and enhancing patient education and support treatment and adherences. Finally, describe patient advocacy, including access and financial resources and community support services. 1990 was a very exciting year. We just left the 80s. We're going into a new decade. Entertainment industry had some great things to take place. We had Will Smith, Fresh Prince of Bel-Air. And then he went on that same year to record a song that summer isn't summer until we hear that song, Summertime. And for those that are from Philadelphia, that is our anthem, because the plateau is where everybody wants to go. And then we also had Big, Bell, and DeVoe in 1990. You know that song we all like to dance to, Poison. Never trust them. Well, I'm not going to say the whole line, but you know what it is. And meanwhile, back at the ranch in 1990, around 1990, we had an African-American surgical oncologist by the name of Dr. Harold Friedman, originally from Washington, D.C., who moved to Harlem, New York, to establish a breast clinic, and he was also the founder. He was burdened by the lack of access to health care for the vulnerable and the underserved population. And as a result of that burden, he established the breast clinic, and that is how patient navigation was founded. Initially, nurses were not used, but as that model continued to evolve, it became known as the oncology nurse navigation, which is a major component of cancer care. So that is what also happened. While the entertainment industry had their stuff going on, we had our stuff going on too in the oncology community. And also, in the late 1990s to 2000s, again, as the patient navigation model gained national attention, oncology nurses began to formally take on these roles. Recognizing their clinical expertise and patient advocacy skills, healthcare systems began integrating registered nurses into the navigation position to manage the clinical and psychological and psychosocial complexities of cancer treatment. By the early 2000s, the role of oncology nurse navigators had become more clearly defined. Oncology nurse navigators supported patients from diagnosis through survivorship, helping them understand their treatment options, coordination of appointments, overcome barriers to care, and manage symptoms or side effects. By 2010, and in that era, professional recognition and standardization had become more prevalent. We had organizations such as the Oncology Nursing Society, which is also known as ONS, and also the Academy of Oncology Nurse and Patient Navigators, known as AONN, contribute to the professionalization of nurse navigation. AONN was founded in 2009 and helped establish core competencies, training guidelines, and certification standards for oncology nurse navigators. The Oncology Nursing Society also played a role in formulating education and certification for not only oncology nurse navigators, but also not only oncology nurse navigators, but oncology nurses. By 2020, everybody know what marked that year, COVID pandemic, until present. Oncology nurse navigation is a critical component of multidisciplinary cancer care. The role has evolved to include use of electronic health records, also known as EMR, and data tracking tools to monitor patient outcomes, involvement in value-based care initiatives and quality improvement programs, and also expansion beyond oncology into chronic disease navigation, because as most healthcare providers know, comorbidities is seen a lot with our patients, so we definitely need to navigate that component as well. Here are some of the key functions of oncology nurse navigators today. Again, coordinating care across all specialties, educate patients, their families, and their caregivers, managing symptoms and side effects, and we'll go into this a little throughout the presentation, identifying and addressing barriers, and also supporting survivorship and end-of-life planning. The role of the breast oncology nurse navigation. During this presentation, we'll be talking about the three components to breast oncology with our patients, and that is the surgical breast nurse navigator, the radiation nurse navigator, and then finally the medical breast oncology nurse navigator. But right here, this is just a real quick overview. So there's addressing and identifying barriers to health care. Breast oncology nurse navigators play a critical role in identifying and mitigating barriers that can prevent timely diagnosis and treatment. They may include financial obstacles. A new buzzword for that is financial toxicity, and again, we'll talk about that. Transportation and logistical issues, that is a major barrier, transportation. Language or cultural barriers, that's another one. So it's important to have interpreters, translators that are available to help our patients so that they can understand what we're telling them. Health literacy challenges, that's another one. Always want to make sure that you're providing the information in a way that the patient, the caregivers, and the family can understand. And also the psychosocial stressors. I don't know if you're familiar with this term called trauma-informed care. Well, now cancer is now being considered as a trauma. So that's why the psychosocial piece is important, that we provide resources for them for that. Also, optimizing care coordination. Breast oncology nurse navigators serve as central points of contact throughout the patient's cancer journey. Their coordination efforts include, again, scheduling all diagnostic tests, consultation, and treatments, facilitating communication between the providers and everyone that's a part of the multidisciplinary team, tracking the progress and following up on missed appointments, which is a key as well, and we'll talk about that later, and the intervention for that. Also supporting transitions of care. This coordination reduces fragmentation and helps ensure efficient patient-centered care delivery. Also enhancing patient education, and you'll hear that a lot through this presentation. And with this slide, it's just reinforcing that we have to educate the patients just so that they have a better understanding of what's going on. And effective education empowers patients to make informed decisions and also to engage and actively be a part in their care. Supporting treatment adherence, that's really good. And I know our first presenter talked about that, building trust. It's important that we build trust with our patients, because once that trust is built, they will listen to what we have to say, because we're all in this together. Like I tell my patients, we are here to get you through this part of your journey, and you are not here by yourself. So along with treatment of adherence, we want to make sure we monitor their side effects and you address them promptly. Encouraging open communication with the patient, also ensuring patients have access to necessary resources, and providing motivation and emotional support. High adherence rates are linked to better clinical outcomes and improved quality of life. Now we will talk about the role of a breast surgical oncology nurse navigator, the care coordination during surgical planning. This is key. The moment that patient receives the diagnosis, because a lot of times the mammogram may be ordered by the primary care physician or the GYN. So once that diagnosis has been confirmed, they will see the breast surgeon. And at that time, the surgical nurse navigator plays a crucial role by coordinating all the necessary diagnostic testing, surgical consultations, obtaining pathology reports. A lot of times, pathology reports come from outside of that particular practice, and that can be very challenging, trying to coordinate, making sure you're provided with the right fax number so that they can send the information. So all of that is important, and they definitely participate in the multidisciplinary tumor board discussions. Scheduling, again, assist with scheduling all the surgery and pre-op appointments, everything that's needed during that phase. And then act as a liaison between the patient and the breast surgical oncologist to ensure accurate and timely communication. Patient education, you hear that you're just going to hear that throughout this presentation. Again, provide education on the various surgical options such as lumpectomy, mastectomy, reconstruction, and again, you always want to make sure this information is provided in patient-friendly terms. And again, preparation for surgery, educate the patient on the preoperative and also the postoperative care that can require drain management and wound care. Again, emotional support, that's crucial. We said that cancer is now considered a trauma. Patients are overwhelmed just with the diagnosis of cancer. That's very overwhelming. They're very overwhelmed when they come to see us. And also, I would like to list as another barrier, navigating the healthcare system. It's very challenging. It's challenging even for healthcare providers. So it's definitely challenging for our patients. And we want to get them through that. So at our practice, we do have resources that we do refer our patients to for the emotional support. I don't know if people are familiar with the Smith Center, and there's also the Cancer Support Community. They offer free virtual telehealth counseling sessions, not only for patients, but for their caregivers and their family. And we find that that helps a lot. And we also refer our patients to support groups. So those things really help to manage the emotional support. Again, we talked about this, the post-operative support and surveillance. So you want to make sure that they come to their post-op visits and receive the pathology report, which is important, because that pathology report will dictate the plan of care for the patient. And again, you just want to assess for any complications, lymphedema, infection, pain, and then you will just implement the necessary intervention. Again, at our practice, we do partner with the NRH. They have like a cancer rehab program. So for patients who are dealing with lymphedema, we will automatically send them to that program. And then also with this surgical nurse, breast oncology navigator, help the patient transition to the next phase of care. If radiation is needed, they will transition them to that, and then they will transition them to the medical oncologist for adjuvant therapy if that is needed, or hormonal therapy. Again, address and identify the necessary barriers that we discussed earlier. And then you do want to collaborate with the social workers, our financial navigators, and the care team to eliminate these barriers. The key outcomes of having the breast surgical navigator role can result in reduced surgical delays, increased patient satisfaction, improved adherence to treatment plans, enhanced communication across the multidisciplinary teams, and finally, a better emotional preparedness for surgery. Now we will talk about the role of a breast radiation oncology nurse navigator. Again, they coordinate the consultation with the radiation oncologist, and they will also play a role with scheduling the planning sessions, and that is where the simulation is done. They want to ensure timely communication between the radiation oncologist and also the other specialties, such as the medical oncologist and the breast surgeon, to be a part of their care. You definitely want to track treatment timeliness to prevent delays or disruption. Again, with the education, you want to explain what is radiation and also review the side effect profile and some of the more common side effects with radiation is the skin irritation, fatigue, chest wall discomfort. And if they do experience skin irritation, which is very common, the radiation oncologist will prescribe the necessary treatment plan just to help manage that side effect. And we talked about this, again, the regular check-in to assess the side effects, and that's really key. And again, collaborating with the entire care team. And then if skin irritation is really severe, you would then submit referrals to dermatology or wound care. And again, the emotional and psychosocial support. I just recently had a situation where we had a Spanish-speaking patient. Her treatment was really complicated. You know, she's a single mom in her 30s. I mean, just you name it, it happened to her. Side effects, reactions to the treatment, but we got her through that because she got her chemo before the surgery. So we got her through the chemo. She had the surgery, finally got through that, and then we discovered that she had stopped going to her radiation. She was getting it daily for 6 weeks, but I think she may have like 2 more weeks to go, and we realized that she stopped. Her daughter, who is a high school senior, emailed me to let me know that that was going on and that the mom was having panic attacks. And so I reached out to the mom with an interpreter, and she was having panic attacks by going into the machine for the radiation. So because of that, she stopped coming. So again, what we did, we collaborated with the radiation oncology nurse navigator, you know, the medical oncologist, basically everybody. And we brought her in with an interpreter, and she shared what was going on. So we now have connected her with psychosocial support. We have an internal psychiatrist, and then we also prescribe anti-anxiety medication. So now that we have been made aware, we know what to do so that we can help her complete these final 2 weeks. So that's some of the things we do. And then finally, we talked about this. You want to encourage and make sure that the patient stay on schedule because it's critical for the efficacy. Because remember, our goal is for the patient to complete the treatment so that we can just continue to provide, you know, quality care and they can have quality of life. So outcomes for this radiation nurse oncology nurse navigator: improve patient understanding and reduce anxiety about radiation, fewer missed or delayed treatments, more effective side effect management, and finally, a higher patient satisfaction and better long-term outcomes. Now, the third component, role of a breast medical oncology nurse navigator, which is me. Again, a lot of scheduling. You know, we coordinate the appointments for chemotherapy. We go over the teaching, get them scheduled to have their Mediport placed. Again, when patients come to see us for the initial visit, they are beyond overwhelmed. I'm sure most of you are familiar with Charlie Brown. Remember the teacher, womp, 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 womp. That's all that they're hearing, and we understand that. So that's why a lot of times I tell my patients, I don't expect you to remember all of this. We will take one day at a time. We are, again, I can't convey this enough. We are here to get you through this. You are not alone in this journey. So we want to make sure we give the patient permission to just understand that they don't have to try to absorb all of this in that one visit because it is too much to process. Completion of these wonderful forms, the FMLA, disability, work-related forms. That is a major stressor for a lot of the patients. They get this diagnosis. So keep in mind, when they get this diagnosis, life is also happening. Other things are happening in their life. And then we know the current climate that we're dealing with, you adding that. But like some people, a lot of the young people say, life be lifing. So that takes place. So with these forms, there's a loss of income. They're afraid that if, they have to take time off, will it be covered? So we recognize that this is a major stress for our patients. So this is another thing that the navigators do. And we know that our providers, because I know I was talking to the oncologists at the table, you're overwhelmed too with a lot of the things that you're doing. So we help our providers out by, we fill out the forms, all we ask is that you sign it. So we take care of that, because there's an incident. I have a friend, her mom was being treated for colon cancer around 2 years ago. As you can imagine, as a caregiver, she had to take a lot of time off. She had presented her FMLA forms to her provider, to the oncologist's office, and it took over a month before they were completed. She lost her job. So then she had to retain legal services so that she can get her job back. So that really made me realize this is important. It's time consuming. Who likes to fill out forms? But I realized that it's necessary. So we tell patients to allow 10 business days for completion of forms, but truth be told, we get them, I get them back to them as soon as I can. And then again, with the multidisciplinary communication, we ensure that the treatment plan aligns with input from the surgical, radiation, and pathology teams. And then we also work closely with the oncologists, the pharmacists, and also the infusion nurses, just to ensure and make sure that the patient understands their plan of care. Patient education. Key. We educate. And for a lot of my patients who speak different languages, a lot of us become creative. Google has become a good friend of mine because we do a lot of chemo calendars, so I have learned how to cut and paste, put it in Spanish. Like I said, it's nurse navigators back to Max the dog. We're going to do what needs to be done to get the job done to help our patients get through this. So we educate the patients, we provide written information, also verbal information, and we provide that information to their family as well. There are some patients where they have 3 or 4 children, and all children want to know what's going on. So why not create a distro list? That's what I do, so that way it's being sent to everybody. Just to try to alleviate as much stress as we can. Side effects, expectations, we go over this in great detail, because that's crucial, because with chemotherapy, there's so many side effects. Nausea, vomiting, fatigue, neutropenia, peripheral neuropathy, just to name a few. So we make sure that they understand how to take their anti-nausea medicine, and also make them aware of the necessary side effects. And for those that might be experiencing peripheral neuropathy, again, with our cancer rehab program at NRH, we will send them to that if needed, as well as our palliative care team. We will submit a referral if the oral treatments don't help. Sometimes we'll use gabapentin, and if that doesn't help, then we'll use other methods to try to help manage that side effect. And again, we check in with the patient frequently. I know I had a patient recently who said, thank you for, when you call, I feel calm. So that's something that insignificant. I'm like, wow, it really makes a difference. Even though we are busy, but we have to do what we have to do to get the patients through. And when they realize, when you say that you're going to call John Doe tomorrow to check on them, and you call, they're like, oh my God, thank you for calling me back. You're building trust with the patient. Because again, we want to make sure that they get through this. And then again, we coordinate with the medical team to adjust any medications. And if they are having significant side effects that cannot really be managed at home, with our prompt intervention, if we need to bring them in for IV fluid or send them to urgent care, we'll do what needs to be done just to make sure that those side effects are addressed. And we also want to make sure that patients know when to seek urgent care, and something that may seem simple but is crucial. Make sure that they have the after hours number, because realistically, a lot of this stuff happens after hours. So you want to make sure they know who to call and where to go. Again, with the psychosocial and emotional support, remember cancer is considered a trauma. They're going through so much, so again, we will refer them to those referrals as needed, and we'll check in with them. And some of my patients, a lot of times we have patients that have high-profile jobs. They're dealing with a lot of stress, and a lot of times we'll tell them, you know what, while you're here, that's not who you are. Right now, you are the patient. So give yourself permission to just be you, and focus on you. And some of them exhale when they hear that. And again, we identify the necessary barriers and deal with them appropriately. And promoting treatment adherence, which is really important, especially with our oral chemotherapy drugs. I'm sure, like with a lot of the healthcare providers and a lot of pharma, you see that there's a lot of oral therapy. So you definitely want to follow up with the patients, make sure they're taking it correctly, monitor them for any side effects. And the key outcomes of the breast medical oncology nurse navigator can result in improved treatment completion and adherence, better management of side effects and fewer emergency room visits, enhanced patient satisfaction and reduced anxiety, and finally, more personalized continuous care throughout the systemic therapy. Patient advocacy in oncology nursing. Some of the key aspects of patient advocacy: access to financial resources, or the other term, financial toxicity. This is a major one. We just had a patient, she just started her chemotherapy for breast cancer. She had she's getting the dose dense, chemotherapy, so she completed that, ready to start cycle 2, but a few days before that, she ended up in the emergency room with a PE and DVT. So they did send her home on, they'd given her Luminox, anticoagulation therapy, and then they gave her a prescription for Eliquis. She left the emergency room, I remember, it was like on that Tuesday, so then she came to us Wednesday, made us aware, we're aware of her situation. Copay for the Eliquis was $400, which she could not afford. So we're like, oh dear. She needs the chemotherapy, but like the provider was saying, well, we can't really treat her, if we cannot, manage the DVT and the PE. We have a phenomenal financial navigator. We actually have 2. I always tell them they're my miracle workers. So I reached out to them because the other thing is, let me add the other piece. She has Medicare. So, and that's the other thing we're discovering, that a lot of patients are underinsured with prescription coverage, and a lot of times you don't know it until you need to use it. So with the Medicare and her prescription plan, her out-of-pocket was $400. So I reached out to our financial navigators. They have an internal grant to help women who are in active treatment, not based on income, with medical bills. So they were able to use that funding. So they were able to do that. We transferred the prescription to our hospital pharmacy, and not only did they do that, they also took the prescription to the patient who was in the infusion center. So that made a major difference to allow this patient to be on continued care, but to also alleviate that amount of stress. I can't begin to tell you, this scenario is more common than we would like to see it. But again, with our financial navigators, and then we also have a specialty liaison person who works with all of our orals for the specialty medications. They work miracles getting the necessary funding and resources, and they know how to apply for a lot of grants and things like that to help patients with this major barrier. And again, like we talked about, they connect patients with the necessary referrals or resources if financial aid is needed. Also, access to community support services. Again, the Smith Center and then the Cancer Support Community, they're wonderful. They have a lot of programs for patients. And again, I encourage my patients to take advantage of the counseling sessions, and also for their family and their caregivers. And another barrier that I did want to mention is transportation. That's a huge one, a huge one. We do have a patient navigator, and they will help patients with that resource, getting metro access. We also have a partnership with Uber. So a lot of times that is a resource that can be used for patients because that is a major barrier. Again, as advocates, we are problem solvers. We always say we are the Olivia Pope of oncology nurse. We tell patients, I will roll up my sleeves in a minute. We're gonna get the job done. We will get the job done. Because the other thing I wanted to mention real quick is prior authorizations. That's getting the approval from the insurance companies for a lot of our patients' treatments. Things are changing a lot. They are denying more and more. We do have an internal team who does handle prior authorizations, but unfortunately they're not clinical. So when we're getting these denials that follow the navigators, we have to submit letters of appeal, to get things overturned. And what's happening now, I'm not sure if people are aware of it, they are starting to deny place of service, especially for your immunotherapy infusion. So what a lot of insurance companies are doing now, they are designating their own place of service, which is becoming much more stressful for patients. John Doe is seeing the doctor, because we basically see our patients the same day as their treatment. So now what they want them to do is see their provider and then send them to another facility. Very stressful, but anyway, we have been able to overturn those things. Yeah, so let me stay on the key. And then again, as the advocate, as we know that nurse navigation is evolving rapidly in responses to changes in cancer care delivery, technology, and patient expectations. Here's a look at what the current and future of oncology nurse navigation role will likely involve. Again, right now we do have nurse navigators across all specialties, all types of cancer, but you're going to see an increase of that. You're going to see navigators that will now be palliative care navigators and survivorship navigators. Also see them involved in genomic counseling, which is like the genetic testing. And that's another thing we do. I forgot to tell you that. As nurse navigators, we also submit all of the genetic testing. You're probably familiar with the liquid biopsy. So we do all of those things through the portal. You'll also see navigators for immunotherapy, which is becoming very popular in cancer care and clinical trials. Also, an increase in telehealth and remote patient monitoring, where patients will be able to monitor their own symptoms and side effects at home. I'm currently collaborating with someone who's working on an app for such a thing as that. AI, we already see that happening. We'll see navigators taking on more leadership roles in the multidisciplinary team and also contribute to policy advocacy. Oncology Nursing Society is already implementing that. And then continued education on disparities in cultural competency and continued addressing health disparities. Some of the challenges ahead and currently being faced, this is not just for navigators, but probably for every healthcare provider. Burnout risks due to the high patient load and emotional demands. Most navigators we have assigned to 2 providers, and we're navigating sometimes over 200 patients. And then the other thing is a need for standardized metrics on how to show an outcome on return on investment. Right now, our services are not billable, but the AONN, they're working on coding and things like that to make that become a reality. Practicing self-care as an oncology nurse navigator is critically important, not only for personal well-being, but also for professional effectiveness. Here's a detailed look at why it matters. And again, this just doesn't just occur, it's just not for navigators, but for all healthcare. We're dealing with patients, again, in trauma, dealing with life-threatening illness, and just dealing with that a lot, it can result in compassion fatigue or emotional burnout. So it's important to practice self-care. And also implement physical exercise, but basically just self-care, what that may look like to you, but it's important. And basically, that's it. So thank you for allowing me to take you through the day in life of a breast Medical Oncology Nurse Navigator. Thank you so much.
So I really appreciate what you do. My question is, in a scenario where a patient is newly diagnosed, and as we know, chemotherapy is toxic to the body.
Yes.
Because it destroys the tumor, it destroys the normal cells. And new patients are often asked to, and I'm going to FMLA, right? New patients are often asked to request for time off if they do qualify to work for maybe over a year or so at your place of work. Most people do qualify for extended leave of absence. And most of the calls will ask the patients to request for time off for maybe 4 to 8 weeks to see how the body reacts or how the body responds to chemotherapy agents before they go back to work. Because work is an added stress.
Exactly.
When your body is already fighting a battle. We have situations where some employers will honor that request. In cases like that, or some will honor the request, and then a couple of weeks later, their body employees will return to work, or will begin to threaten the employee. In cases like that, how do you expect? Because you can't go back to the physician, you can't do anything. Thank you for the form that you signed, because I know firsthand how hard it is to navigate through that. Having the forms sign and send it back to your HR at work and having it processed. How do you take care of employers who do not approve for that extended time of the treatment?
That's never been my experience. Our patients, I'm gonna be honest, because we, like I said, we fill it out. I'm very generous. I usually give them 3 to 6 months or whatever, and then I think it's how you complete it. Number one, I don't have the best handwriting, so I'm thinking they're probably like, look, we're not trying to decipher through this stuff, so we're just going to approve it. But no, seriously, the more information, I list every side effect that you can imagine with these drugs. And I think that helps. So again, to answer your question, I think how they're completed, just tell them to just list every side effect. And when they see that paragraph of all of those side effects, my patients get their forms, they get them approved. And I've been doing navigation for 8 years now, so I've never had one come back and say that they were not approved. So I think that's the key.
Okay, so just to add to that, so if it gets approved and maybe, like I said, 4 to 6 months is usually the time to request treatment, or of course people work in between. It's approved and then after a while, the employee is now actually return to work. You and I know they're still dealing with people and all that. How do you take care of that? Because we want the patients, in this case, to receive the treatment and be well enough to return to work. Exactly. That is a dilemma. It's fighting for their lives, and then the source of income is also on the line. Because if we've seen them get paid, they get laid off, and then because of the source of income and insurance, now it's an added strain on the providers. How do we take care of the employers to make sure that our patients continue to care while the job is still safe?
Now that's a great question. For patients in that scenario, they'll ask me, can I write a letter? So we'll just write a letter. Again, they get that same paragraph of all side effects and the reason that we are recommending and advising that the patient needs to be off of work, as they are continuing this treatment. So again, I think it goes back to the documentation. And when I tell you, when I list every side effect, and when they see that, and because they're going to get, I tell them I'm like a politician, you're going to get the same response from me. So you're going to get that same paragraph of those 20 side effects. So I think the documentation is what really helps. Yes.
How do we know? How do we get more? Because I'm a nurse. I'm a bedside nurse. I know I may be able to educate and all that. But all these things that you are saying, I think we really need enough navigators to be able to help these patients. So do you think we have enough? And if we don't have enough, what do we do to have more navigators?
That's an excellent question. I think, because it is a part of the oncology care model, President Obama, you implemented that as well. So more cancer centers are, including them. And if you ever look on LinkedIn, you'll start to see more positions for oncology nurse navigators. Because you're right, it's it's needed because the care is so complex now, so complex.
My name is Beatrice. I work with MedStar too. Listening to what you just presented, see, being a public health nurse, I'm thinking about reaching people where they are, where they live, not in the big hospitals. See, we're in a level 1 hospital, me and you, but people in the local set up. How do we pull them out and provide them with these resources we're talking about? Because I'm a nurse. I don't know too much of all this navigation. I do bedside most of the time, navigating with health insurance, navigating with pharmacy, medication availability. Sometimes we say the patients are not compliant with medication. It's not that they don't want it, but they cannot reach the system to get what they want or what they need. So what do? It's kind of difficult in this country, not to talk about my country, Nigeria, where we don't have the system set up. So what do we do to make sure we reach these people where they are, where they live, where they work?
That's great. This conversation needs to continue. You're right, in the community, in the healthcare community, in the community, because it is needed. I know, again, at Washington Hospital Center, they have some various research initiatives with community health workers. So they're actually working on a program now where they want to have community health workers in the community for our breast cancer patients. I'm sorry, not breast cancer, for all types of cancer patients, to help address that. But you're key. These type of forums, I know my table mates, they're trenched in the community. That's how we're going to have to get the word out. Again, in these type of forums in the community, so that patients can be made aware that there are resources available, but you don't know what you don't know. So that's true. And I know Hospital Center do a lot in the community as well. Yes. Mm-hmm. Is that a doctor? Oh my God, we worked together back in patient oncology, what, in 1990? Yes.
Great presentation. Thank you very much, and thanks for coming to this symposium. So I guess the question I have is, we have heard about patient education. My take about oncology nursing, I started off as an oncology nurse, is family involvement.
Yes.
Education is not just for the patient, but also for the whole family. What are some of the challenges that you face in getting families to commit in this? You may educate the patient, educate. But what are the challenges that you get to get the families fully committed in the education process and also in helping taking care of the patient?
Adama, that's a great question. It can be challenging. What is very interesting, a lot of people don't have family support more than you realize. So that is a challenge. But for those who do have family support, we just have to stress it again. You want to create that trust. And when they see that you are invested, you really care about what's going on with that patient and you're here to help them get through. When they see that, my experience is that they're they will do the buy-in. I had one patient, I could tell that her son, he was young, probably in his 20s, whatever, very skeptical, like, oh yeah, they said they're going to follow up, they're going to call, they're not going to do all of that. But when he saw that I followed up with an email the next day to him, kept up with the mom the entire time, that stress was alleviated, and he trusted us. So that he felt comfortable. He's like, okay, they're really going to take care of my mom, so I understand what's going on. So I would say, once you identify the family, just encourage and let them know that they're part of the team, and also establish the trust with the patient and the family. And I think that trust really makes a huge difference. But thank you so much. And it's just so good to see Adama, because I think, Adama, when we were working, you were new nurse, right? Yeah, because I was there as a trainee, in 1990. Yeah.
All right, Ms. Glenda, thank you so much. That was an awesome presentation. On behalf of the AWCA family, we have this little token to present to you. Thank you.
Thank you so much.
That was really awesome. And thank you all for the wonderful questions. Like someone said, we can't overemphasize the importance of having patient navigators in hospitals or clinical settings. We have lots of testimonies, lots of personal stories. As we all know, we work with cancer patients. I have a story. There's this cancer survivor, breast cancer survivor, who I want to say was saved, even though we know that patient was saved by divine grace, but was saved by a patient navigator, just like Ms. Kosa. This patient had appendectomy, surgical removal of the appendix, and was sent home. You know, in nursing, we always document, and we better document what we've done, right? So there's a part where you discharge patients, and you also document follow-up call 2 to 3 days post-discharge. This particular navigator was diligent enough to follow up with this patient. Cut the call. Hey, how are you? How's your pain? You taking your medication? Do you have any concerns? This patient had gone home in pain. And we know in that procedure, of course, they open up the patient and there's air gets into your body and there's air trapped in some areas, rib cage and all that. This patient was experiencing severe pain. She couldn't yawn, she couldn't laugh, she couldn't cough without excruciating pain. And when that diligent patient navigator called and heard the patient's concern, the first thing she said was, come right back. Do you need an ambulance? The patient said, no, I can take myself. This patient went back to the hospital and was rushed back into the CT radiology, and we had a CT scan done of the chest, of course, chest and lungs. We thought there was probably fluid, PE. We were thinking there was some blood clots. Guess what? The results came out. The lungs were clear. There was no PE, there was no blood clots. But what did we find? We found the patient had some nodules in her breast. That was how her breast cancer at a stage 3 was found by a patient navigator. That singular phone call. So, like we say, thank you so much for all that you do. All the patient navigators around the world, we do appreciate you. We can never underestimate the work that you do. You are lifesavers, navigating through the patient's care from the time of diagnosis through the time of healing. I mean, having someone who looks and sounds like you makes a lot of difference. There are patients who are, when they're being diagnosed, there's anxiety, there's fear, and all kinds of things. You know, having someone who understands you makes a lot of difference. I know that firsthand, so we do appreciate you. So for now, we're going to go. I think we're right on time. It's break time. It's time for us to move around this beautiful room and look at our wonderful vendors. A round of applause to all our vendors. Thank you so much. We really appreciate you. Thank you all for sponsoring this event. We don't take that for granted. So it's time for us to now visit the tables of our farmer friends and see what they have for us. We'll be back at exactly 10:15 a.m. to continue with the program. Thank you.
Yeah, we have this. This shows our newest indication for prostate cancer for men's health. And yeah, I mean, we're just sort of here to support this organization because a lot of the times it's at the prompting of a female family member of some sort, sister, daughter, wife, to kind of go and give chat. So are you obviously consulting? Yeah. Do you have any questions about prostate cancer in general? So, well, African American men are away from prostate cancer. It's a really exciting time right now. We have a lot of combination therapies that are letting men live just a normal, healthy life, and they normally pass away from other, like heart disease or something else. So yeah, I think basically I think it's like anything caught early enough, cancer is curable. Yeah. So yeah, I think the idea is definitely just kind of get your Oh, yeah. I mean, just to know, right? It's always good to know. Yeah. 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 Nice to meet you. Hi, how are you? We sort of have the male equivalent of breast cancer. We have prostate cancer. Yeah, so Rebecca is a second generation therapy for prostate cancer. As you know, prostate cancer is probably like 10 to 15 years behind where breast cancer is. So now, I just say that, like before it was very sequential, like if this failed, try this. But now combination therapies are coming out, and we're using combination therapy with Lupron, which is just an anti-therapy, really choking off the testosterone to really chemically capture the male, because that's the hormone that's being produced for the prostate cancer. Yeah, no, really, it's just, I think, if anything, we're supporting the organization because it's important for men to just really get out and just get tested. Because it's a simple blood test, and they'll kind of know, especially African American men, are greater risk for prostate cancer. No, and yes, and so just like anything with medicine, like that was the standard of care, and that was kind of it for 20 years, maybe longer. But really, like in the past 5 years, this space has been exploding. Like nothing happened. Yeah, like nothing's happened, and now everything is happening, right? Like all at once. So I mean, even with our urologists, like there are literally 3 or 4 new studies being done in each of the conferences every year about. I think the gist of it is really when is docetaxel.
Yes, just as a family nurse practitioners in the practice, men come to refer them to urologists. As a family, as family nurse practitioners, more like we're diagnosing everybody.
Okay, they're getting up too early. They're getting up too often at night, and because it's like it doesn't occur to the man, oh, I should go see my doctor, see if there's something wrong.
Of course, yes. Sometimes they'll diagnose it as just.
Right.
You don't have to sit in the chair. You just got. You're right.
Yeah. It's a good quality of life. You don't have to sit and get in it. Yeah.
And then you can just take.
She said, and she's on Facebook. You get the tea on Facebook. She's like, and she's on Facebook.
That's kind of get in that shit. I want y'all looking at Simplexes. I don't know if you know about the Synonym. Have you heard about the Synonym? You got it. Make sure you get my card. So if you want to call me and say, Marcus, come tell me some more. This is a sticky card.
Draw on a moderate or a highly emetogenic regimen. This drug's got a 90+%.
We both started new at the same time, so that's why I
And I have, and Temecco is for metastatic non-small cell lung. So it's a rare form.
So we have two products, Bavencio and Avalumab for bladder, Merkel cell, renal cell cancer, Temecco and Tepotinib for non-small cell lung,
maybe those things
and then exon skipping mutation. What do you practice?
I'm a researcher with NIH.
You're right.
You're at the NIH?
Yes, I'm at the NIH.
Even though we're not right
so
now,
you know
we're right
that
here.
about the law that
Right
changed
here. You can a few blocks
about how you needed to include diversity now in the clinical trials.
Yeah. Yeah, I was at the FDA, then when they kick us out, I joined the
I think it'll
NIH as a contractor under contract.
It's gonna grow.
Nice. What do you do at the NIH?
Senior researcher.
And who? The next time.
Yeah, on HIV,
I think there's
mostly infectious disease.
I think Tony
Lyme.
Robbins is in town.
Infectious disease, my background.
I was in infectious disease for 10 years.
Okay. Never changing the game. Gonzaga, we need you back again for a group picture.
Okay, I will be introducing our third speaker. She is Ms. Shamista Mohaptra. She is the Cancer Screening Program Manager at Maryland Department of Health. Ms. Mohaptra oversees the CDC-funded Maryland Breast and Cervical Cancer Early Detection Program, the CDC-funded Colorectal Cancer Control Program, and the Cigarette Restitution-funded Cancer Prevention, Education, Screening, and Treatment Program. Prior to her current role, she worked at an FQHC in New York City as a health educator, and later as a population health manager, where she managed a CDC-funded patient navigation program for cancer screening, in addition to managing a patient caseload. She is a U.S. Army officer veteran who served in Iraq and Afghanistan. Ladies and gentlemen, a round of applause for Ms. Shamista.
Okay, hello. I'm Sharmista. As we said, I'm from the Maryland Department of Health. So these are going to be our learning objectives for today. I'm going to preface by saying that, in my prior role at the FQHC, I was a health educator and I also patient navigated patients. So the first half of this talk, I'm not expecting to teach you all anything, y'all are professionals, but I'm just going to convey the talking points that are important for patients and for the general public about colorectal cancer screening and prevention. And then the latter half, I'll go into some epidemiological data from Maryland and our safety net cancer programs. So first thing I want to do is a pulse check. This is kind of like what I would do in the waiting rooms is go ahead and place on your body where you know your colon is. Where is it? Yeah, okay, it's down here in the lower part of your abdomen, okay? All right, so can anyone tell me what does your colon do? It gets rid of poop. Yes. Okay. So I like to start off with patient education and just talking about the digestive system. Okay. So we eat food, and yum yum yum, goes down our mouth, into our throat, our esophagus, gets to our stomach. We digest our carbohydrates, that goes out into our bloodstream. Then the rest goes on into our small intestine. We digest our fats and proteins, that goes out into our body, and whatever we don't really need, that keeps on going to our large intestine or our colon. And what does our colon do? It ends up pushing out that solid waste out of our body as stool or poop. So it does a really, really critical job for us, and so therefore we gotta give our colon some love. We gotta take care of it, okay, and not be ashamed of what our colon and what our butt does for our body, right? So that's why we really need to think about colorectal cancer screening. Colorectal cancer is a disease in which cells inside of the colon kind of grow out of control. And usually these cells start off as tiny little bumps or polyps in the body. And not all polyps turn into cancer, but usually most cancers in the colon do start as polyps. So for screening, what we want to do is find those polyps as early as possible so that we can take them out of the body before they can turn into anything possibly more harmful. Okay, so that's one way we can give love to our colon, right? So there's different types of cancer in the colon. The most common are adenocarcinomas. So here in the little picture, just want to show you those little bumps that you can see, right? They look very small and tiny, but this is what screening is trying to do, is find those little bumps as early as possible so we can take them out and remove them before they could possibly grow into something larger that we can see. As you can see the progression, right? Getting into a larger growth, possibly an adenocarcinoma, possibly an invasive cancer. We don't want that to happen, right? So if we can take out those tiny little bumps and polyps soon, great. We don't need to have those other outcomes possibly happen later. There are some lesser common types of cancers that are listed here: carcinoid tumors, lymphomas, sarcomas, but most importantly is we just want to think about finding those early little polyps and getting rid of them. Now, for colorectal cancer, most times the most common symptom is no symptom. We just can't really feel polyps growing in our body, okay? You're just not gonna know that something weird is going on. So that's why it's really important to do preventive screening, to find any of those possible abnormalities before they turn into visible or physical signs and symptoms. So some of those signs and symptoms could be change in your bowel habits, such as diarrhea, constipation, narrowing of stool that lasts for more than a few days. Our poop tells a story, right? Okay? So we need to be mindful of what's going on there. Any kind of blood coming out in the stool or from the rectum, that's unusual. Unexplained abdominal pain, aches or cramps that don't go away. Unexplained weight loss, you don't know why. Or iron deficiency anemia that's not caused by some other known condition. If these symptoms appear, definitely go and talk to your provider so that we can, they can discuss whether you need to, get a screening earlier. So there are various risk factors. This is important for us to talk to our family and also share with our providers what is going on with our family history and what's going on with our own known personal history. Such things as if you know that you have inflammatory bowel disease like Crohn's disease or ulcerative colitis, if you have a personal or family history of colorectal cancer or known colorectal polyps, if you have any genetic syndrome such as familial adenomatous polyposis or Lynch syndrome, then please share that with your provider so that you can discuss, do you need to start screening at a younger age? I'll say I had a friend, mid-30s, male, he went to the ER because of blood in the stool. Freaked out, and then after that whole ordeal, he talked to his parents and found out that his mom has Lynch syndrome. He just never knew. And had that discussion happened, he could have avoided this kind of scary interaction with his own body, right? And if he'd been routinely engaged with primary care, he could have gone to his PCP and had this addressed. So we want to avoid these kind of scary situations just by talking to our loved ones and sharing with our providers. There are other risk factors that cannot be changed. Age, we growing older, okay, can't control that. Our racial and ethnic background, our sex at birth, any personal history of gallbladder removal or personal history of radiation to the abdomen or pelvis area, these are risk factors we can't change. However, there are many that are in our control. We have agency over, okay? If we're not moving around and being active, that's a risk factor. If we don't eat enough fruits and vegetables, if we're not getting enough fiber in our diet, or we're eating a lot of processed meats, those are risk factors. Being overweight, drinking too much, using tobacco too much, these are risk factors that raise the risk of colorectal cancer. And about half of all colorectal cancers are linked to the factors that can be changed. So it's not inevitable for us to get colorectal cancer. We do have personal agency, okay, to reduce the risk of getting colorectal cancer. So how can we lower that risk? Colorectal cancer is very common in the United States. About 1 in 25 people will develop it at some point in their lives. There are cultures around the world in which it's so rare, like it's almost unheard of. But come to America and eat the American diet, colorectal cancer is very common. So that's why it's really important that we screen for colorectal cancer. So we advise people at average risk to start screening at 45. And there's various types of tests. And screening tests not only look for cancer, but they also look for those polyps that I talked about, pre-cancers, before they could even turn into cancer. So we can do a lot to avoid hardship down the road by screening. And there's lots of options which we'll go into soon. Other things that we can do to lower the risk. Eating more fruits and vegetables and whole grains. These foods have fiber. Fiber is what I like to think of as nature's toilet brush. It's going in the body, in the bloodstream. It's cleaning out your vessels and like pushing out that gunk and waste and dead cells, and it's pushing it out into the stool. And your colon is, got that fibrous stool, and it's exercising and like squeezing out that stool out of the body. And so it's doing a lot of good work to clean out the inside of your body. So eating fiber, great for us. Also, getting regular exercise. This helps with maintaining weight control. When we're overweight, that just puts a lot of additional stresses on our internal organs that we don't really need. So exercising, managing our weight also helps to reduce the risk of colorectal cancer. And then obviously, don't smoke, limit your alcohol consumption. These are poisons. They're fun poisons. We like to partake in these poisons sometimes, but let's not overdo it, right? Smoking and alcohol, these are toxins. They do these unusual things in our body. They can like kind of harden the cell linings of our bodies, and they just kind of facilitate the growth of weird things. And we want to minimize that, so we should save these for just special occasions, or not at all, right? So, what are the important reasons for screening? Obviously, I mentioned that we can find precancerous polyps that can be removed before they turn into cancer. Colorectal cancer is often seen as a silent killer because, again, most times you just don't feel anything unusual until it's too late. So colorectal cancer screening, it can decrease the number of people diagnosed with colorectal cancer. It can reduce deaths. We can prevent or detect cancer sooner when it's easier to treat. And it just reduces healthcare spending. By improving screening, we can cut the costs of insurance spending just by doing screening, right? So these are all of the really great outcomes of doing screening. So here's the good news. We've got lots of different options for colorectal cancer screening. All of them are fairly safe and effective. And again, for average risk adults, we recommend starting at age 45. So the point of screening is that we want to find any of these polyps and get them out before they could possibly turn into something more harmful. And there's various types of tests. The most common that most people know and that a lot of providers like to encourage is colonoscopy. Okay, colonoscopy, you have to take bowel prep to clean out the colon, and then you go to the gastroenterologist or the GI, and they might give you some anesthesia to help you go to sleep. And the procedure takes about 20-30 minutes. They insert a long, flexible tube up through the butt and checking out in the entire colon. And that flexible tube has a tiny little camera at the end that takes pictures inside. I think that's pretty cool. And then also, if there's any of those unusual growths or polyps, the GI doctor can then and there cut them and remove them from the body, because that little tube also has a little snare or a little like knife to cut it out and take those polyps out. So it's literal cancer prevention. I think it's the only test in which you can literally prevent cancer from possibly happening. Now, I know a lot of people find colonoscopy to be kind of cringe and like, ugh, it's gross and I don't want to think about it. There's even guys who have a little macho sense of like, oh, no, this seems, and I'm going to say it, this seems kind of gay. And this is a misconception that we need to dispel, okay? Because that kind of thinking, it's just harmful to the person who thinks that way, right? It's not harming me, it's harming you, right? We want you to have a full, long, healthy life. So do your preventive care, okay? Do your colonoscopy. Also, I'd like to say a lot of celebrities and influencers, they'll like do these crazy juice cleanses and they'll pay for a colonic. And I say, hey, if your health insurance is gonna pay for bowel prep, okay, and anesthesia, why not get your bowel cleaned? You know, you can shed a pound or two and then you have a nice nap. All of these benefits, why not do it, okay? Now, understandably, maybe not everybody is ready, willing, and able for colonoscopy. It's okay, we have the other options. And it's important to present the other options to our patients and the public. So we also have CT colonography. This also does require bowel prep to flush out the colon. And in this situation, there's a special machine that takes pictures. A small tube is put in through the colon, but that only is there to kind of push in air so that it allows the pictures to be seen better. It doesn't actually have a camera itself. It doesn't actually have any tools to remove any polyps if they're found. So if there are polyps found, you do have to come back for colonoscopy. But if everything is clear, then this test is good for 5 years. Oh, I didn't mention, for colonoscopy, if everything is clear, it's good for 10 years, okay? So CT, good for 5. Now, we also have some non-invasive screening tests. These are take-home stool-based tests. So we've got the FIT DNA, otherwise known as Cologuard. You might have seen ads for that. So this requires the patient to use this little test kit, put it over the toilet, and take a dump into one of these containers. And you're sending in a giant stool sample in the mail to the lab, and what they're gonna do is look for hidden blood in the poop, as well as any signs of altered DNA, okay? And if that's all good, this test is good for 3 years. The other one is the FIT. This one is probably the simplest one. It is basically just a card, so a person just has to go to the bathroom in the toilet, there's a little brush, you get a little sample of poop in the toilet, put it on the card, mail it to the lab. Okay, and the lab is going to look for hidden blood in the stool. This test doesn't look for any DNA, so because of the limitation, it's only good for 1 year, so you have to do it every year if you're clear. Now, of course, if there's any findings, let's say there is hidden blood in the poop, altered DNA, then you definitely have to go and do colonoscopy, okay? So everybody has to be prepared mentally that if there are abnormal findings, I'm committed to following up, right? And doing the entire sequence of care. Because it's no point in just doing one thing and then if there's something unusual, you just stop, right? The point of screening is to early detect, right? And get you to treatment as soon as possible. So there are also some emerging screening tests. I'm not necessarily advocating for these right now because they are still very new, but I want you to be aware that they are on the market now. So we've got a stool RNA test called ColoSense. This is looking for abnormal RNA and blood in the stool. And then there's also a blood test called SHIELD. This would have to be done in a provider's office because of taking blood. And this is looking for changes to cell-free DNA, proteins, or other markers. So these have only come out in the last year, so they're very, very novel. It is important for us to talk to our patients and our community about the risks that come with screening. We need to be frank and transparent with them, okay? We're not selling them a golden ticket and there's no issues. We have to be frank about the possible concerns, right? To alleviate everyone's anxieties, okay? So the more that we explain and give details, it kind of helps assuage their minds. So, you know, we definitely need to acknowledge that, yeah, it can be kind of scary, it can be anxious, but like, here are the pros and cons, and let's talk about them. And you know, if you're not ready for colonoscopy, then let's start off with the stool-based test, and then we'll work our way, maybe in the future, to colonoscopy. This chart here is for providers to kind of take a look at the comparison of the different types of screening tests. So I did mention the intervals for normal findings, but I also want to point out adherence. So again, a lot of providers, they just default to colonoscopy. They don't really bring up the other options. But as you can see here, the patient adherence to doing colonoscopy is one of the lowest. It's not one that a lot of people love to do, okay? And so only about 1/3 of patients who get referrals do colonoscopy. But some of the stool-based tests have higher adherence. They're more likely to do them. You can see almost in the 70% of patients actually doing them. So again, take this into consideration when offering the different tests. Don't just default to one, okay? Now, I understand that a lot of providers, they lean towards colonoscopy because the sensitivity was very good, right? Almost up to 100%. And so that's why it was kind of gold standard in their mind. But I will want to point out that there was a resistance with uptake of Cologuard, but Cologuard just put out a new product called Cologuard Plus, and they've done a lot better with their sensitivity and specificity now with this new product. So again, consider all of the test options when presenting to your patients. Okay, at Maryland Department of Health, this is the message we are trying to push out, and we encourage you as providers to do that as well. Emphasize the best test is the one that the patient is willing to do. Okay, while we all know that colonoscopy is, the established standard, we do have non-invasive screening tests, such as the FIT, such as the Cologuard. So let's offer them as alternatives to our average risk patients, right? Those who don't have any known personal or family history, get them, offer them that alternative. Again, a lot of individuals are reluctant to do screening colonoscopy, and we need to acknowledge that, right? And we talked about patient navigation, right? What are your barriers and hesitations? If they can't take off time from work, then it might be hard to do the bowel prep, right? Because you have to be close to a bathroom, right? And then the next day you have to take the day off because you're going to have your appointment, you're going to be under sedation, you need to have an escort home. So those might be kind of challenging for some patients. So again, let's offer them the stool-based tests first, have them do that, and then we'll proceed down the line, right? And use that time to prepare, hey, if this comes back positive, let's talk about who is going to be able to help you for colonoscopy, if you need to do that, right? Get them to start thinking. Okay. And then I also want to point out in Maryland specifically, we do have some areas with long wait times. In the Lower Eastern Shore, there's only 5 GI providers for 3 counties. So the appointments are out 1 year. In some of our even more populous areas, like where we have our safety net programs, we also have long wait times. So we are really trying to encourage providers that, to alleviate these appointment backlogs, if you know that it's an issue in your area, to triage and refer your patients that are at high risk, right? You've done the family history, the personal history, the risk factors. If they are high risk, definitely you need to refer them to colonoscopy. But if they are average risk, they don't have signs and symptoms, then offer them the stool-based test so that can alleviate that appointment backlog, right? We need to really front load the patients who need colonoscopy for sure, okay? So this is an appeal to all of you providers out there. So the screening recommendations in terms of age, the United States Preventive Services Task Force recommends 45 to 75. This little icon here says 45 is the new 50. So it was in 2021 that the age lowered from 50 to 45 because unfortunately, younger people are getting colorectal cancer. It's really unfortunate. And again, I personally blame the American diet, okay? There's something up with the food. So, this is why that screening age has gone down to 45. So make sure that you're aware and you are pushing this out to your patients. Now, it goes up to the age of 75. After 75, it's really a decision between you and the patient and how healthy are they? Are they vibrant? They're moving and they've got long quality of life ahead of them, then you can continue colonoscopy. If they have a lot of comorbidities, mobility is an issue, then 75 is kind of the high end of screening. So this chart shows the different pathways for screening. Path A is patient decides that they're going to do colonoscopy. So they're going to do their bowel prep. If there's no polyps found, fantastic, come back in 10 years. If there are polyps found and removed, it's sent to pathology, and that's going to determine whether you need to get treatment because you have cancer, or it's pre-cancer, so we want to surveil you in the next 1 to 3 to 5 years. So that's one pathway. The other pathway is if the patient picks stool-based test, right? So if they do that and they do FIT and it's normal, come back in 1 year. If they do Cologuard and it's normal, come back in 3 years. But if there is something found, then you definitely need to do colonoscopy and continue on that pathway. So make sure that the patients know that it's not just, oh, I do the stool-based and I'm done. No, if there's any findings, we gotta prepare you to do colonoscopy. Are you ready to do that? So Now I want to talk about health insurance coverage for screening. Oh my gosh, we've talked about health insurance. It is like it's a nightmare. Even as professionals, okay, there's so many caveats. This here is, I would say, majority of people fall under this, right? Most of us have health insurance through our employer or through the marketplace, right? So those plans must comply with the Affordable Care Act. So these rules apply. There are very rare insurance plans that don't have this, but most of us have this. So colorectal cancer screening should have no cost sharing. That means no co-pays, no deductibles, no co-insurance for the following things. The GI consult prior, okay? Any bowel prep medication, anesthesia, polyp removal. So this is one thing that was kind of contentious was, oh, we found polyps, now it becomes diagnostic. So that was a charge. I put these two asterisks because that's a little caveat. So the Centers for Medicaid and Medicare, they still have a bit of a 15% co-insurance for now, but by 2027, that should go away, so that there should be no cost sharing. Also, any pathology done on any extracted polyps, also no cost sharing. And let's say your patient started off with a stool-based test and there was a positive finding and now they need colonoscopy, that follow-up colonoscopy should have no cost sharing, okay? So this is the rules for screening. Now, for those there is distinctions between screening and diagnostics. So if polyps are found during screening and you need to now come back in 1, 3, 5 years, then that follow-up test, then you might have to have cost sharing. You might have to pay your co-pays or deductibles. Also, if a patient is determined to be high risk and they have to start screening at a younger age, then their insurance might require them to have cost sharing. And so then they have to talk to their insurance to figure that out. Here is a list of some treatment options. I'm not really going to go into it because I'm not an oncologist, but again, promoting the use of clinical trials here. We always want to encourage patients that, if there's some novel trials, please participate. Okay, so now I'm going to switch over to talk about some epidemiological data, especially for Maryland. So this is a chart on colorectal cancer incidence. The red line, that's United States data, and the blue line is Maryland data. So as you can see, Maryland has done comparatively well with the rest of the country, and and it's been declining over time. So this is really good news that incidence has been declining over time. Here's a chart on mortality. So as you can see, the gap between the U.S. and Maryland has closed, but we've all been, trending downwards. So this is positive news. I will throw on a little bit of history here. So in 1996, this is when the USPSTF first set colorectal cancer screening guidelines, and then in 2001 is when the Centers for Medicaid and Medicare started covering colonoscopy for average risk individuals. And that insurance coverage is what I would say sped up the downward curve, just insurance coverage. Really good to have that. And then in 2021, again, as I mentioned, USPSTF lowered the age eligibility to 45. Some good news for Maryland. Back in 1999, we had the 6th highest colorectal cancer mortality rate in the nation, but as of our most recent data in 2021, we're now 25th. So that means we're like mid-range. So we've done a lot of improvement in Maryland thanks to screening. Here's some further statistical data. So colorectal cancer is the 4th leading cause of cancer and 2nd leading cause of cancer mortality. In Maryland, we had about 2,500 new cases and over 900 deaths in 2021. The age-adjusted colorectal incidence rate is about 34.5 per 100,000 Marylanders. But if we break it down by demographics, you can see that males have a higher incidence than females. And then when it comes to racial disparities, interestingly, our black and white population is even. But compared to our Asian and Hispanics, they're much higher. I speculate that because the Asian and Hispanic population tends to be more of the newer immigrants, we haven't had as long of a time with the terrible American diet. So that's my thinking, is that we still have the old food culture, and that's kind of what's saving us for now. But give us 3 generations, I'm sure we'll catch up. Okay. The mortality rate is 12.9 per 100,000 Marylanders, and here you can see continued disparity between males and females. And then now we start to see the breaking out of the racial disparities with Black individuals facing higher mortality than their peers. Here's a map of the jurisdictions in Maryland of colorectal cancer incidence by where people reside. So the darker the color, the higher the rate is, and the lower the color, the better. So I really can't explain why Dorchester County has the higher incidence rate, mystery, but there's not really a clear trend here. And then when it comes to mortality, we have some more counties that are not faring as well compared to the US. Again, no clear universal reason why. I mean, Garrett, there's a hospital there, but they tend to have lower screening. But on the other hand, Dorchester and Wicomico, they do have higher than average screening. But I speculate that maybe because they don't have hospitals there, like there's hospitals in the eastern shore and then the lower eastern shore, so maybe I think it could be an access thing. Again, very hard to gauge. And Baltimore City, well, this is a high Black population, right? And we know that mortality is affecting that population. This chart here shows the stage of diagnosis. So I've circled colon cancer. So the blue line is capturing colorectal cancer at a local stage. So we want more blue, okay? So as you can see in comparison with prostate, breast, uterine cancers, we are capturing more of those cancers at the earlier stage. Good. But with colorectal, we're not doing as well. Only about a third of those cancers are found in the local stage, and then a third in the regional, and then about 20% in the distant. So we need to do better at capturing colorectal cancer at an earlier stage, right? When treatment is easier and less traumatic, less expensive. So in 2021, we had about 72% of Marylanders 45 to 75 who self-reported being up to date with colorectal cancer screening. This is pretty good. This is higher than the US average, which is why I think we've done so well in the last 20 years with our incidence and mortality. But on the other hand, only about 47% of those of colorectal cancers diagnosed are detected by screening. So that means that the majority of colorectal cancers are found when signs and symptoms have shown up, and that's not good. We don't want that to happen, right? We want to do more screenings to find cancer early. This chart breaks down again the self-reported screening for colorectal cancer by race. So you can see for Marylanders, white and Black Marylanders report screening at pretty high levels. They're on par. But screening for Hispanics is on the lower end, so we can do better at reaching out to that population. And then here this compares self-reported screening between the sexes. So males slightly lower than females. Now I want to switch over to talking about our safety net programs in Maryland. So every county jurisdiction in Maryland receives funds from the Maryland Department of Health for no-cost cancer screenings. We offer it for breast, cervical, colorectal, and some jurisdictions even offer for lung and skin. We're hoping to include prostate once guidelines come out, okay? Shout out to prostate. So to be eligible for the clinical services, people have to live in Maryland. You don't have to be a documented resident. We definitely serve the undocumented. You just have to live in Maryland. You need to have a household income that is lower than or equal to 250% of the federal poverty level, have no insurance or be underinsured. So, if they have Medicare but they don't have secondary insurance and they're low income, this program is also there for them. And then also be age and risk appropriate. So our no-cost screening programs provide patient navigation. And what this includes is, if this person doesn't have a primary care doctor, we'll connect you to one nearby. They'll assess you for health insurance. If you can get health insurance, they'll connect you to the Maryland Health Connection. Great if you get insurance. If not, it's okay. Our program is still here. They'll also assess people's smoking status and connect people to the quit line or to cessation services. We also will help people connect to transportation and interpretation services. And then of course we'll cover the cancer screenings themselves. So in the case of colorectal, we offer Cologuard, we offer colonoscopy and diagnostics at no cost. And also we'll connect people to other community resources. So, we've had situations where, again, somebody needs to undergo treatment, but they're struggling to make ends meet. So we've had our nurses at the local programs, kind of help them find rental assistance, food, getting their kids, help as needed. So they do a lot of work to connect to the community resources. And then of course, if somebody is diagnosed with cancer, we will connect you to resources for treatment. So these are the various funding sources in Maryland for treatment. Obviously there's insurance through Maryland Medicaid and the Maryland Health Connection. I threw up here the Maryland Breast and Cervical Cancer Diagnosis and Treatment Program. No, it's not colorectal, but I just want you all to be aware that we do have a program specifically for breast and cervical cancer treatment. It's there. Unfortunately, we don't have a dedicated fund for all the other cancers. So we have to kind of piecemeal resources for them. The Cigarette Restitution Fund is one of those. This one is kind of a big pool of money that includes for education, screening, and treatment. So there's not, again, a dedicated amount for treatment, but we do our best to try to, move money around if people need to get some money for treatment. We also have the Maryland Cancer Fund. This one allows up to $20,000 per person throughout their life to access money for treatment. And then also other payment sources. Hospital financial assistance and charity care is huge. Every hospital in Maryland has a financial assistance charity care policy. It is by law, okay? And hospitals cannot say, oh, you're undocumented. Nope, that's not legal, right? They have to serve people regardless of status. The only metric they can use is income, okay? And they have various scales. Some go as generous as up to 400% FPL, but that's the only thing that they can measure somebody for financial assistance is income. Also, hospitals can't say, oh, you're not in my service area. No, any Marylander can go to any Maryland hospital to access the charity care. If there are any issues or you're getting told, confusing information, we do have state resources to help navigate. I don't have it on the slide, but I want to say out loud, there's the Health Education Advocacy Unit. It's under the Maryland Attorney General's office. They have free mediation for patients and even family members and navigators to help access financial assistance at hospitals, or even mediate with insurance companies too. So if you're getting all this confusion with the denials of care, the Health Education Advocacy Unit can kind of help mediate and resolve that. So this is my final call to action. Let's proactively discuss all of the options for colorectal cancer screening to patients, not just colonoscopy. Provide all of the options, and to men in particular. Those are the ones, the data shows that we really need to close the gap on, okay? And then we also want to prompt and prepare patients to complete the entire continuum of care, from consult to screening to diagnosis to treatment, okay? We don't want to just stop midway, okay? We really need them to fully understand what they're committing to, and that hey, the whole point of this is to find cancer early, and then if we find it, we're gonna get you to treatment early, right? That's what we're doing, okay? It's not just to send poop in the mail and that's it, no, okay? And then also finally, utilize the safety net programs that exist in Maryland. We're here for you. I know that some of our neighbors, like in DC and Virginia, they have some breast and cervical programs, maybe not colorectal, but Maryland, we got safety net, okay? So come and turn to us for those resources. Thank you very much. Open to questions.
That was really elucidating, and to know that we can have care in Maryland is really amazing. So that should not be an issue. My question is screening for elderly people above the age of 80 and 70. I don't know where the guideline comes from that if you hit 70, you don't get screened, or 75, you don't get screened, or 80, if you don't get screened. I know if you have comorbidities, then it's okay, you might not get screened. But a lot of primary care physicians tell a patient once they're over 70 that they don't think it's a good idea for them to go for screening. I don't know if you've heard that before, or if there is anything, especially patients who have gone through treatment for colorectal cancer. I suppose they're supposed to be screened till the end.
Through 75, through 75. Okay, so the upper range is 75.
Why did you have to stop at 75? That's my question.
I think it's just in terms of the weighing the pros and cons of screening versus not, right? After 75, typically people have a lot of other health issues, maybe. So that's where it's a decision between the provider and patient.
That's,
you know,
yeah.
if you are healthy, then yeah, we can continue screening. But as I mentioned, if people have a lot of other chronic conditions, you know, or they just can't be as mobile, then the doctor might say, you know,
so that's
we don't need any.
That's the myth. That's the myth I want to let people be aware of. There are so many 75-year-old patients who are people, not even patients, who are entitled to screen. And we know the older you get, the more likely you are to have colorectal cancer because you have more mutations as you get older. For you to just stop midway at 75, they have grandkids, they have so many things to live for. So 75 should not be a cutoff. I think, like you said, it should be a discussion, and we should encourage our patients who have good quality of life to continue to screen. Now, I would not recommend colonoscopy for all of them because even though they might appear good, once they go through that prep, they might not recover again. So that is why, no, you can't just say 75.
You just said it now.
What I'm saying is that you are, no, if it's 75, you can do the fit, you can do the stool. That's what you need to do. You have continue to screen. You don't have to do colonoscopy. That's what I'm saying.
But she just said it. So if you do the fit and identify there's any sign of cancer, then that's when you recommended the colonoscopy. And that's why you said it about anesthesiology. If you go through all that, they might not recover very well. That's why they try to put that 75 years, or 75 is a good number to get patients.
I don't think so. That's what I keep saying. There are two things I'm saying. I'm saying one, a 75-year-old who is fit.
But she said selectively, right there, selectively. Clinicians should selectively offer screening for colorectal cancer after considering everything in that age range. So they did selectively. So it's up to the provider to know this is my patient and this is what they're going through. I think they're fit for this. Because first of all, if you find out they have colorectal cancer at 75 and they don't have good quality of life, what are you gonna do?
My take
take
right now is that we should, as providers, encourage our patients who are fit to say age is not a cutoff point for you to have a screen. It is now left for you as like a lot of patients come and say, my primary care says I should not have colonoscopy. You have to individualize this. There's no cutoff. Like say 75 is the age for you not to continue. That is what I'm hearing as a provider. I hear a lot of my patients say, I'm not supposed to do that anymore. I actually stopped at 70.
So this is something that we need, like education, need to continue. Even our providers, to tell them that the fact that you are 70, just looking at the scan and say, just looking at the age and say you don't qualify, it's a discussion that you should have.
She says 75.
That's what I'm saying, that patients themselves, it's a myth that
that's when you are educating them that it's 75, not 70.
Even at 75. My mother is 98 years old.
Yes.
She just went to UK by herself.
Very good.
There are people now, older people who are getting older and who have a good quality of
Very
life.
good.
But they should not come.
At 98 to do colonoscopy.
If she wants to do it, I would recommend
Very
it.
good.
Yes, why not?
Yes.
But we don't have, it's true. This is a discussion that you should have with your patient. You should have this discussion. And because what happens is that at 75, a patient who has good quality of life comes to you and says, oh, I stopped doing my colonoscopy at 70. And now she comes with colon cancer. It's depressing.
They stopped it at 70, but it's not a recommendation by USPSTF. They didn't recommend you to stop at 70. They said 75. You stopped at 70. Maybe your provider that wasn't following the
so if we are aware that there is controversy and this discrepancy, it is then our duty, and in a forum like this, to always have this discussion with our patients and don't miss that period of time.
That's why we come here to learn.
That's why we are here for our patients. And from my own experience, that's why I want everybody to be aware of it.
Yes. Very good. You learn, you educate them very much.
I'd also like to say that, it's great your mom is 98, but we have to think, would she want to get cancer treatment at 98? That's something she has to decide, right? Like, does she want to spend the last few years of her life
that is the decision. That is the decision for the patient.
And she might, she might not want to do that.
That is the decision for the patient to make, not the physician. That is.
But we'll come to this to learn. So as she says 75.
So you cannot say because my mother is 98, she might not want it. That's not what I'm saying. What I'm saying is that let's give her the option. Let's give her the option to make up her mind what she wants to do. You should not just say because you are 98. That's what I'm trying to bring out. You can't make decisions for your patients and say because of your age.
I could support you on that. We are all saying the same thing.
Yes.
I work in a cardiology cath lab. So I see like 90-year-old patient coming to do valve replacement. And sometimes I ask myself, for what? So we are just saying the same thing. It's their option. If they want to do that, then their family, it's up to them.
Honestly, you should
They
give
don't want
them
to do it, it's up to them.
I have a 96-year-old lady going through chemotherapy. 96. For 1 year, nobody could do a biopsy for her. 1 year, I sent her to everybody. Nobody wanted to do a biopsy. Why? Because of her age.
This is government issue.
But as providers, we should help. No, you can't make that decision.
Let me add something here. When you sedate a patient that's above 75, it's harder to get them recovered. So even if the patient wants it at 90, the provider will have to have some kind of talk with them and say, do you know, if you go through anesthesia, waking up, the chance of waking up might not be there. So you talk with them and you advise them. I think it's better for you not to go through anesthesia. We had a 103-year-old patient that came for a procedure. The doctor was blunt because he asked the question, what is the survival rate? If I call the doctor's name now, the doctor said, I don't have nothing to compare with because I have not done anybody more than 90 and you're 103. That answered the question, so the son took him home. So above certain age, you might advise your patient to decline certain tests. Thank you.
Thank you all so much. We've had some really interesting deliberations going on, and I have a feeling that it will continue.
Definitely.
They'll probably have to kick us out of this space, and we appreciate all of that.
through it all, we're learning. Just like someone rightly said, most providers would hesitate before they send people of certain ages for certain procedures. And it is our duty as health providers to question things like that. I do it. You know, if you see people of a certain age and you see certain procedures and blood work that's being routine for them or prescribed, please advocate for those patients. We all mean well, but the question is, what are you looking for? And if you find that, what are you going to do with it? So if you're sending someone who is over 80 for a procedure that entails anesthesia, the chances of them breaking up, we have to always think of that. The condition of their heart, sometimes we've had people, seniors who've been scheduled for procedures, and oftentimes the cardiologist will cancel the procedure because we know ejection fractures and a lot of things. You know, their bodies, their brain, their heart conditions might not survive the procedure itself. So interesting conversations, we do appreciate that. It's an eye-opener, regardless of the age cutoff. We and our loved ones have the right to decide what we want to do with our bodies. But again, as healthcare providers, please always continue to advocate for your patients. Mr. Sarah, we do appreciate you. Thank you. That was energy and all the information. Thank you so much. So on behalf of AWCA, we'd like to give you the certificate of appreciation, Mr. Mohaptra, in recognition of your outstanding presentation at today's symposium. Your expertise elevated the conversation, as you see, and advanced the mission of global cancer care.
Also, if you have more questions for her or any of our speakers, feel free to, take it up so the conversation goes on. We're just trying to work with time, but thank you very much.
That was awesome. Okay, so we're going to invite our next speaker to the podium. She is Ms. Radka Agnafo-Boyer. She is a research, Ms. Radka Agnafo-Boyer is a research associate at Johns Hopkins School of Medicine. She has a bachelor's degree in biology from Binghamton University and a master's in public health from Columbia University. She does conduct research on cancer prevention and screenings. She's currently leading a study identifying barriers and promoters to colorectal cancer screening for Black immigrants and refugees in the metropolitan Baltimore and Prince George's County. From 2016 to 2024, RepCare proudly served as the director of the Banton Neighborhood Leadership Program, an intensive leadership fellowship and mentoring program for emerging community leaders in Baltimore City. She applies her passion for mentoring by guiding BNLP graduates in professional and personal development and serving as a faculty advisor to the Africa Business Club at Johns Hopkins at Johns Hopkins Carey Business School. She established Dance Gift, named after her mother, to provide academic and professional development guidance to students and professionals, primarily from Ethiopia, other African countries, and Africans. In addition to her extensive experience in research, she has extensive experience in community engagement, youth development, sexual health, community assessments, program evaluation, strategy planning, community coalitions, and program management. She currently serves on the board of Omaricha Space, Kenya, Voice of Africa, Gapbusters Inc., Ghana, and Maryland, and Seeker University, Ivory Coast, Ethio-American Chamber of Commerce, and is a member of the Baltimore HIV Planning Group Commission. That's a mouthful right there. Ladies and gentlemen, please join me in welcoming Ms. Radka to the podium.
Hello, great to see you on Saturday morning. Okay, so I'm gonna take you on a little bit of a journey. I hope you can hear me, okay? And I'm taking you to southern Nigeria. Okay. We're gonna be exploring how the southern Nigeria community connect with their gods, the Orishas. And these gods are Ogun, Osun, Shango, Olodumare. On the 45th moon, everyone's birth, they have to eat this porridge, tasteless porridge. They have to consume all of it. And then there will be festivities recognizing the person that has just turned 45. And it'll be a big village celebration. But, as I said, he or she has to finish eating that nasty tasting porridge that's not flavorful. Like we Africans like flavorful food, this one is just plain non-flavorful. And after consuming that, and all that celebration, early in the morning, the villager then gets his jambe and enters a cave. A cave early in the morning. And every time that happens and people go into that cave and they come out, they don't talk about their experience. They don't talk which God they met. Is it the wisdom God? Is it the punishment God? Is it the God of guidance? Who do they meet? The only sense that they get is when they come out of the cave, the expression of their face or their body language. Some may come out excited, smiling, and still not share their experience. Some are sad, droopy eyes, drooping, and still not share. So this time, it's Dare's turn. So there was a full celebration in the village, drumming and singing and dancing, because Dare, the next day, is going to enter this cave. Dare was a bit nervous. He has eaten his porridge, he really hated that. But anyway, he participated in the celebration and everything. The evening was over. He went back to his little hut. In the morning, he got up early. He had this tremendous fear about going to the cave. I don't think I can face that. I do not know what to expect or who I'm going to meet. So I'm just going to pack my stuff and run away from this village. So he did. Before anybody woke up, he ran away. Run. And then he got tired after a long distance. And he sat down just to take a break. And then at a distance, he sees this beautiful woman. It's like, my eyes really looking at someone here? This deserted place? And the woman started approaching. And the woman said, Dare, where are you going? It's like, how did you know my name? My name is Ori, and I know everyone. I'm in everyone's business. And you are running away. Why are you running away? I am so afraid because I don't want to go into that cave. I don't know what I would find. I'm so nervous. And this person, and so Ori said, I did that too. I run away when it was my turn. And I never went back to my village. And I'm so ashamed, and I regretted that because I left my people. I want you to think about that. I urge you to go back to your people, and I urge you to face the cave. So Dari thought about it, and he said, okay, I will go back. He went back to the village and apologized to the elders and apologized to his family. And he was forgiven. He went into the hut, got his djembe, and approached the cave. He went into the cave, and you have to go deep, deep into the cave before you start drumming. As loud as you can make it, to call out the gods, the right God that's connected to you. Then he heard lots and lots of drumming, and then he sees a figure approaching him in bright light. Dari! Welcome to the cave. I am Orunmila, the god of wisdom. Did I do wrong? Was I good? Where's my future taking me? Dari, you can relax. I am so glad you decided to make this trip into this cave. You've been good because you've been following what I have guided you to do. And as a result, you're clear to go. Your path is looking good. Dari was so excited. Thank you. Said, I have one more thing to share with you though. And what is that? Why don't you people come to the cave more than once? I do not see them. So please go back and share that this is not a one-time incident, that they need to dare to come back into the cave a bit more. Dari said, thank you, I will do that. I will go and deliver the message. So Dari left the cave, smiling, happy, and he did something no one did before. He was ready to share his experience with the cave. And he told about who he met. He told them that the wisdom God told him, you have followed the right path and you're gonna go and do well, you're gonna be fine. And they want us to keep coming again and again, because one-time visit to the cave is not enough. And we need to support each other, because it was Ori that I met while I was running away that told me to have the courage to go. So we should support each other and go into the cave and not be afraid of the cave. And there was such a celebration, more festivities and drumming and dancing, because Dari shared the wisdom that he heard and now transferring it to the entire community. So my story about Dari ends right there. I hope you see the connection of that story to the topic that I'm going to be talking about today. So I have a study on identifying barriers and promoters to colorectal cancer screening in Black immigrants and refugees in Baltimore City and County and Prince George's County. It's a qualitative study. We have two aims. The first one being to identify the barriers and promoters to colorectal cancer screening. And then the second part is to develop a community education based on our findings from phase 1, specific to cultural issues. I'm not going to cover much around trends around colorectal cancer because it has actually been shared before with my previous colleague, presenter from Maryland State Department of Health. We're doing a great job of reducing colorectal cancer mortality because we're doing a great job in terms of early diagnosis through screening and treatment. But I think she has also mentioned that we are seeing increasing rate of colorectal cancer in those under 45. And there are many questions, there are many studies, and we do not know the reasons why. But there are some speculations. So, why are we doing this study? So colorectal cancer is the third most common form of cancer and the second leading cause of cancer death. And African Americans have higher CRC rates, and screening rates are lower among minority and immigrant groups. And then there are significant disparities in CRC mortality between whites and African Americans in Maryland and nationally. The why also includes that while Maryland, Baltimore, and Prince George's County, approximately 30 to 40% of both whites and blacks have never been screened. And mortality is significantly higher in the African American population. And then Prince George's County, the disparity in mortality between whites and black African American rates are 14.7% versus 20.9%. For the nation, black and white mortality rate is 1.32, 1 per 32, meaning for every 100 deaths among whites, there are 132 deaths in African Americans. Cancer screening for black immigrants is lower, and our population, immigrant population, continues to grow. By 2030, the immigrant population is supposed to exceed 70%. With the current trend, I do not know where that's going to take us, so I'm not going to get political. And so there are reasons for lower CRC screening range from socioeconomic to cultural to health barriers in our immigrant population. There has been a paucity of research, so when you try to identify colorectal cancer screening rates here in the United States or studies related to that, it is going to be a very huge challenge. There are very, very few studies looking at Black and Caribbean immigrants, African and Caribbean immigrants, and their colorectal cancer screening, cancer screening in general. So what often happens is that in our population, we go to seeking care when there are serious symptoms, and by then, stage 3 and stage 4 of cancer has kicked in. Okay? So screening saves lives. Screening is very important. There are so many methods for screening that has already been covered, so I'm not going to get into that. And for our study, the expected income is to really eliminate factors influencing colorectal cancer screening in our Black, African, and Caribbean immigrant population. And so we'll identify unique characteristics and strategies to increase screening rates and identify understanding cultural factors that influence screening. So our method includes doing a focus group discussion with African and Caribbean immigrants, Baltimore, Metro Baltimore, that includes the city and the county, and also Prince George's County. And we're looking for those that were screened and also for those that have not been screened. And we ask questions related to what motivated you to be screened, or what were the barriers to screening? Why weren't you screened? We had several partners in this effort and worked with us in terms of thinking through our research study and providing information, but also assisting in the recruitment. Let me just say that recruitment has been really a big challenge, I think for various reasons. One, for political reasons, people do not really want to come forward and provide information about their immigration status. And secondly, I think our population is just not used to being involved in research studies. So those are major challenges that we had to face. Recruitment was extremely, extremely difficult. And if we do not participate in research studies, then we really cannot have our issues targeted and addressed in a way that promotes our health. So that is one thing that we really need to figure out. How do we encourage people from African and Caribbean community to be involved in research? So again, even though I have all these people, all these partners, it has been like really extremely challenging to recruit participants for our study. We have here the flyers for our study, recruiting those that have been screened and those that have not been screened, and how much time it takes in terms of participation time, and also they're compensated for participating. This is the data. So we were able to recruit 25. In actuality, we recruited about 50 people. Initially that said yes, but when it came down to really coming to our focus group discussion and participating, they really dropped out. So that participation continues to be a challenge. So you see the breakdown of those that have been screened and not screened, and then on the country of origin for folks, and the majority are Nigerians, second Ethiopians. I have posted up here some of the qualitative information garnered from this study, and this one is for folks that went through, that have been already screened. So I'm going to pause here so you can take a look at some of the information shared, and then I'm going to ask you to just point out what are some things that really speaks out to you from what you read regarding those that have been screened. What speaks out to you? What stood out to you when you look at this? Yes?
Okay. Thank you for the presentation. What sticks out to me is the number 3 that said, in my circle, we talk mainly about breast cancer. I would like to think that whoever said this has to be a woman or a lady, but maybe there has to be a better way to get the message across that is for both sexes. One of the things I found out some years ago, we might need to use influencers in the community for any of these programs. We had a minister from Nigeria who had colorectal cancer. She was very, very popular, but it was a hush-hush. Mm-hmm. Nobody knew. Mm-hmm. She's female. So if that type of influencer at the time had spoken up or spoken out about her cancer, that could have made a lot of difference. That would allow other people to start paying attention. So I'm not sure how best we can change the messaging.
Thank you so much for sharing that. Yeah, influencers are really important. But then you also pointed out that we do not talk about the C word. People don't even want to say cancer, the C word. So if we don't talk about it, we don't normalize the conversation. We are fearful of addressing that. I mean, look at Boswick from the Black Panther. He did not talk about what he was going through. We do not know until he was close to dying what he had, that he had cancer. His mother told him not to talk about it, not to reveal. This is really one of the things that's really hurting us. We're so afraid of cancer, we do not talk about it. It remains hidden. So thank you for sharing that. Yes?
No, I was just going to add that it's not even just cancer. It's just the culture we came from, where you're brought up from, and just like in the hospital, your colleagues might be saying, oh, I have diabetes, or I have hypertension. We don't share. Whatever you have it. So they don't know what you have, but you know what they have. So that's just our culture. We don't say, as soon as you say this, like, oh, you're going to the hospital, and you say, hey, I hope they don't find cancer. They will just think, oh, you're already cursing yourself. Why are you even saying that word? Please just say, God forbid, though, it's not for me. So it's our culture, too, that is the problem. So we're not discussing it.
Thank you. And those are some of the cultural pieces, nuggets that we're trying to find out and see how we can change them for the positive. Because culture is really very, very important. We do not want to go counter the culture, but we want to work with that culture to identify ways that we can really prioritize our health and promote it, and through our communal exercise. And I think one of them, maybe the bottom right, talks about taking her husband for his appointment colorectal cancer. But there was another group that revealed that someone in their class tested positive for colorectal cancer, and the entire group decided to go together for colorectal cancer screening. So that's the kind of communal, the cave story, diary story, communal encouragement to be screened, communal encouragement to have conversation about cancer and normalize this conversation. Great points, thank you. Yes?
So specifically relating to the colorectal cancer, I think one of the barriers that we're having in our community is not only are we not talking about it, but when we talk about it, we talk about the negative side of it. Like culturally, like, you know, one of my colleagues is just mentioning, when we think about how the procedure is done, in my culture it's like, you know, having to put something through your rectum. The first person that's going to, you know, really talk, you know, be against that will be your spouse. It's like, who want their wives, you know, rectum to be accessed by another man? You know, those kind of things. So cultural barriers, and what you really hear about it, instead of magnifying the benefit of it, we're not talking about the benefit. We're just, magnifying the negative procedure itself.
Beautiful.
So because of that, a lot of people are not having procedures done.
Beautiful. Thank you so much. Yes, we tend to talk about the negatives. We tend to amplify that death, so-and-so died of cancer. We don't hear as much, so-and-so was diagnosed with potential cancer and got the polyps removed, or got treated and survived. We tend to amplify those that have died. So what that creates in our mind is that it is a deadly disease. Okay, equating cancer to death, and that is not the case, because tremendous contribution has gone into science, into the treatment, diagnosis and treatment of cancer. So we need to amplify the voices of those that have been treated. So thank you. And we also need to talk about the procedures, and so the misconception that people have about the procedures, and also how men think about the insertion of the scope and how that is a challenge to their masculinity, and that someone's going to be looking at their butt. The only thing that they're looking at the butt, inside the butt, into the colon, is really whether there's cancer or not. And so there are so many barriers to address. Thank you. Anything else before we move forward? Okay. So let me just go on. So the screening, the cleansing was also a challenge. So here's to summarize then our findings from those that have been screened. Okay. So among those that have been screened, so you see the motivators is the preventive health attitudes. That distinguishes them from those that have not been screened. They have this mentality that preventive health is really important. And what we hear again and again from our community, the African American community in particular, but also the Caribbean community, is that there isn't that culture of preventive care growing up in our continents, in the Caribbean and also in Africa. So that lack of preventive care focus is carried here as immigrants. So we have to really shift the thinking about preventive health and the importance of preventive health. And you do not wait until symptoms. Many of people that we talked to that have not been screened said, I don't have any symptoms. But do symptoms always present themselves early on? No. Okay. So there are lots of education that needs to happen. And health literacy, personal or family experiences, clear provider referrals. Referrals by the physicians that you need to get tested is just so important. And then easy outpatient colonoscopy process, really a one-time place where they can get all the information that they need to be screened. And then addressing belief in screening as proactive healthcare, so really focusing on that. The barriers that they shared is that fear of diagnosis, which is why I started with the cave. That cave story, I hope you're able to really decipher that. It has so many messages, and we created that cave story actually ourselves. Well, and we're proud of that. And then there are cancer-related stigma, and that's why the people do not share that they have cancer. Reluctance to discuss the health issues, financial concerns, which we really should eliminate, because in our conversation, and as the previous presenter covered, that there is really no excuse around financial concerns, because as long as you have health insurance or, and if you're underinsured, then we heard about the various coverage that's available for us. I'm going to move forward, and so here are some that from those that have not been screened, and what comes out consistently is that they have limited knowledge about colorectal cancer, and when people don't talk about it, and there's this perception that you go to a hospital, it's a money-generating process, and you're really not gonna get accurate or authentic health service. So just to summarize then, these are the major things that came out from those that have not been screened, and their barriers are really about discomfort with screening procedures, aversion to stool collection methods. I do not want to touch my stool, that keeps coming up consistently. Busy schedules and appointments, and we really don't have the time. Primary focus in terms of children and family, without really thinking that if you're not there, if you do not live, then family will suffer. So really, if you, and the support of family is really taking care of your own health as well. I'm just going to skip it. So the peer influence is really, really important. Like I said before, it's really influencing each other to be screened and to go to screening together. Study challenges, like I mentioned, the difficulty recruiting participants, discomfort with stool-based screening, and lack of interest in focus group discussion, we are still recruiting people, so I encourage you, if you have people that have not been screened, please, we would love to have them in our study for our discussion around screening. So that is what we're doing right now, doing community education based on the screening, based on the focus group discussion, based on the promoters and barriers that we discussed. And this is our education outline quickly. So we're prioritizing health, so having conversation about the importance of prioritizing preventive health. We include either storytelling or testimonials, because hearing from people that have been impacted is powerful in our community. Fear of the unknown, so we really need to address that, and the pain and procedure, so demystifying the whole process. Yeah. Normalizing the conversation on cancer. Overview of cancer, colorectal cancer screening, and emphasizing prevention, symptoms, and healthy living, and screening options. So giving a variety of screening options. There's one that fits all. And then cost and patient navigation is available, and then post of survey. So to close, we are recruiting participants that have not been screened, and screening education. And then if you are a resource or you want to participate in this study in any way, please, we would like to hear from you. Give us some guidance about any of this, and especially about our approach to community education based on the promoters and barriers that I've identified. So here's my contact information, and thank you, and you had your hand up.
So it has to be, they have to be insured to be screened?
Excuse me?
They have to be insured to be screened? Do they have to have insurance?
Oh, you have to have insurance to be treated or to participate? To participate in the study?
Yes.
No, we do not even ask anything around the insurance question. Yeah. To be eligible is just over 45 and live in Prince George's County or Baltimore City or Baltimore County.
Okay,
Yeah,
so
and is an African or Caribbean immigrant.
Absolutely. Yeah. So if they can't be able to, they don't have transportation, do you provide transport?
Transportation, so for our focus group discussion or community education, we will provide transportation, or we come to where people are, or we do it online via Zoom. Yeah, so we'll meet people wherever they are. The most important thing is we want to get this done.
Absolutely.
Yeah.
Thank you.
This study is really great promise because really hardly any research like this has been done. So any assistance you can provide would be tremendous. Yeah. Any other question or comments? So please contact me if you're interested in supporting us on this study. Thank you so much. Oh, you have a question?
I was going to share that we're also partnering with them to help in disseminating the information and to make sure that people participate in this type of research. The only way our population can get better results is to participate. So for those of you who are here, churches, cultural organizations, let us know. Then we can come and share with the group the benefits of participating. We have to help ourselves. Nobody can do it for us. So thank you very much. We appreciate that. We'd like to say thank you for your time. And we hope, hopefully that, the community will come and that we can do more for what you're doing.
Thank you so much, Ms. Rabka. I do appreciate that. So we're going to take a quick, that's not a quick. We don't eat like way in the military. So it's lunch break right now. So while we go on lunch break, we'll invite the sponsor of today's lunch, We had Bayer Pharmaceuticals sponsor today's lunch, and I have the pleasure of calling on Dr. Nancy Dawson. Dr. Nancy Dawson, and she has a couple of words for us while the lunch is being served. Thank you.
University in Washington, D.C., and I am the director of GU Medical Oncology there. So I've been specializing in GU Oncology since 1999. And I have specialized in prostate cancer for over 40 years. And just to make a theme on what we were all just talking about colorectal cancer, maybe I should have a show of hands. I had my last colonoscopy 4 years ago, and I'm about to be 72. I work full-time, I'm very active, I have no really serious medical problems. So, am I supposed to get my next colonoscopy?
Yes. Yes.
Of course. My husband, on the other hand, is 75 and he absolutely refuses to have his colonoscopy. So, I can't convince him. So I'm going to be talking today about prostate cancer. In particular, I'm going to be talking about a drug called Nubeqa, or darolutamide. And this is a drug that actually just got a new indication about a week ago in metastatic prostate cancer. So not everyone gets screened for prostate cancer, and not everyone has it caught early. And some people who even have it caught early eventually get metastatic disease. But we're going to talk today about Nubeqa and its role in the treating of metastatic castrate-sensitive prostate cancer. It basically means newly diagnosed disease that has spread. And for those of you who aren't prostate cancer specialists, we're usually talking about cancer going to your bone and to your lymph nodes. I am presenting on behalf of Bayer, and I'm compensated to be here, and I'm going to comply with the FDA regulations about what I can talk about. So we're going to talk a little bit about prostate cancer. We're going to talk about Nubeqa, which is also known as darolutamide, what it is, why we're using it. We're going to talk about a study known as ARANOTE, which is the study that was the basis of its most recent approval in metastatic castrate-sensitive prostate cancer. We're going to talk about ARASENS, which is another study that was a basis for approval of it in metastatic castrate-sensitive prostate cancer. A little bit about dosing, and a little summary about why this therapy might be helpful to your patients, or maybe relatives or husbands or other people that you know who might have metastatic prostate cancer. Being a person who specializes in prostate cancer, I don't know if any of you read Up to Date, but I've written a section on how to manage advanced prostate cancer for 25 years for Up to Date. So I know a little bit about prostate cancer. So even while sitting here listening to the last talk, I had a physician text me about her dad, who's 93, who has prostate cancer. She wants to know what to do. I thought it was interesting, especially since I was listening to his talks about access to care, because I said he had localized disease, he's still on hormonal therapy, and I said, and he never got radiation. And I said, why not? And they said, well, where he lives, he doesn't have access to it. And and so he couldn't get radiation. So where we live, we have access some of the time, but not all the time. And some things prevent us from having access, such as barriers that we've been talking about, not just where you're located. So we're going to talk about Nubeqa. Nubeqa has 3 indications. It's approved. Its first approval was about 6 years ago for something called non-metastatic castrate-resistant prostate cancer. That means men who have been on hormonal therapy for cancer that has not spread, and then they have progression of their cancer. So it's called castrate-resistant, a term that offends many people. But it's not metastatic. And so in that setting, it was approved because it delayed the time to developing metastases by 2 years. It's also approved in metastatic castrate-sensitive disease in combination with androgen deprivation therapy. Those are drugs that lower your testosterone, which is the main androgen in a man's body. And it was approved with that and docetaxel, which is a chemotherapy drug, about 3 years ago, based on a study known as ARASENS. And then most recently, in June, gee, that seems really recently, 2025, it got approved with androgen deprivation therapy, so just what we call doublet therapy for metastatic castrate-sensitive prostate cancer based on a study known as ARANODE. I can't find anybody who can tell me why they call these studies ARAMIS, ARASENS, and ARANODE, but I've concluded that darolutamide is an androgen receptor antagonist, and so I'm just guessing ARA is androgen receptor antagonist, and then they just chose a couple letters to go after it that would make an acronym you could say. So it's indicated, as I said, for metastatic castrate-sensitive prostate cancer, both with and without chemotherapy. And it has some warnings associated with it. But there is a very slight increase in ischemic heart disease, and we know we're talking about populations with hypertension, hypercholesterolemia, maybe treated, maybe not treated. I actually had a patient come in with widespread metastatic disease, and I said, well, you've got high volume disease, you should go on triplet therapy, which we're going to talk about. I said, but you know, you haven't seen a doctor, you don't take your medicines, your blood pressure is 240 over 160, and you know, and you've got lymphedema and a non-healing wound in your leg because you won't do anything your doctors say. So I said, do you want to live or you don't want to live? Just tell me. Okay? I'm going to start you on one thing. I'm going to lower your testosterone, and then I'm going to send you out, and you're going to go get your blood pressure under control, and then you're going to come back. If your blood pressure is under control, I'll start you on darolutamide. And then I'm going to send you back out, and you get that edema off your legs and get that wound to heal. And if 6 weeks later you come back and your wound looks okay, your blood pressure's okay, I'm going to add docetaxel chemotherapy. By the way, he did everything I said, much to my shock. And his PSA is now 0, and he's doing great.
Awesome.
So, you know, we gotta work with them. We gotta work with them. So it can cause ischemic heart disease. You do need to get your blood pressure under control, your cholesterol under control, your diabetes under control before you go out of this. And that may be a way you can negotiate with the patient because they really do want to be treated. So 1 in 8 men are diagnosed with prostate cancer. 1 in 3 to 4 men who are African American are diagnosed with prostate cancer. Every time you have a first-degree relative who has prostate cancer, it doubles your incidence. So the guy who came in and told me he had 7 brothers and they all had prostate cancer. And I said, well, what do you expect? You have prostate cancer. We see over 300,000 men diagnosed each year with prostate cancer. The rate's been going up, and it's not because the disease is becoming more common, but the incidence of it is going up. We are both screening maybe a little bit more than we were, but the number of deaths is still about 36,000 deaths a year. So a lot of men die of prostate cancer, despite what some people think. You know, people think that because you have prostate cancer, you're not going to die of it. You know, you're going to die with it. That's not true. 36,000 men a year in the United States die of prostate cancer. If your cancer spreads, you are going to die of it. So this is the disease progression. Some men start with localized disease. About 40% of men who think they're going to be cured with surgery or radiation have a recurrence of their disease. And it's usually initially biochemical only, so you only see the PSA is up. And then eventually those men, if they get hormonal therapy, when their disease is just biochemically recurrent, they can progress and then be non-metastatic castrate resistant, or they can go on and get metastatic disease, as I mentioned, usually goes to bone and lymph nodes, and eventually it becomes metastatic castrate resistant. You get that disease and you die of that disease. So The reason that what we think about when we're looking at men with metastatic castrate-sensitive prostate cancer is we're saying, can we make them live longer? Can we make them delay their time till their cancer progresses? And can we minimize the adverse reactions? So we want something that's tolerable and something that improves their outcome. And then you negotiate with them. So the goals of therapy, we don't really want them to progress from castrate-sensitive to castrate-resistant, because that's when you start having increased complications. So if you look at the annual mortality in a man with metastatic castrate-sensitive disease, it's 16%. When you look at it when they're metastatic castrate-resistant, it's 56%. And so you look at your 5-year survival rate drops significantly, and the cost of your care goes up significantly. I mentioned this is a disease that goes to bone 80% of the time. It goes to your bone, you break your bones, you become a couch potato, you get a clot to your lung, you get pneumonia, you spend a lot of time in the hospital, and you're miserable. So that's what you're trying to delay. So darolutamide, we have, these are what we call next generation or novel hormone therapies. These are what we call second generation anti-androgens or androgen receptor pathway inhibitors. And we have darolutamide, which is Nubeqa, enzalutamide, and apalutamide. And what androgen receptor inhibitors do, and we have a little, let's see if this works on this. There we go. Okay, so this represents an androgen receptor, and your androgen receptor is on your prostate cancer cell. And an androgen right here wants to bind to that androgen receptor, and it wants to stimulate that cancer to grow. Nubeqa sits in the androgen receptor, and it inhibits the binding of androgen to the receptor. So the cancer cell is not being stimulated. It does two other things. It actually decreases the ability of the androgen receptor to go into the nucleus of the cancer, and it inhibits its ability to bind to DNA. So it has a triplet activity, which results in the cancer cell not being stimulated to grow. Darolutamide has been looked at in animal models, a mouse and a rat. They didn't do this in humans. They weren't checking to see whether it crosses the blood-brain barrier, but it has a very low penetration across the blood-brain barrier. That's the importance of that, is the drugs that cross the blood-brain barrier that are being used to treat prostate cancer can cause CNS side effects, the number one being fatigue, or the increased risks of falling and getting fractures are partly related to crossing the blood-brain barrier. Darolutamide has a very low penetration across the blood-brain barrier. So we have the seizures could potentially occur as a result of a drug that can cross the blood-brain barrier. So in the Arisense trial, the seizure, in the Aranote trial, the seizure rate was 0.2%, and in the Arisense it was 0.8%. So there is and we don't know whether medicines for seizures help at all, but there is some slight increase in a risk for seizures, but it's a pretty low number. The Aranote trial was the trial that was the basis of its most recent approval about a week ago. And this was a trial done, it was a global trial, it was done all over the world. It was in Africa, Asia, South America, North America, Europe. And it was a 2-to-1 trial, so, and it was not, it was a trial that was, the size of the trial was intended to achieve statistically whether there was an improvement in radiographic progression-free survival, which means how long before your cancer gets worse by X-ray, and you're still alive. And so it was a 2-to-1 randomization. People, they wanted to appeal, I think, to people who wanted to get Nubeqa, so twice as many people were randomized to get the Nubeqa with androgen deprivation therapy, so a drug to lower your testosterone, and the other group got a placebo plus their androgen deprivation therapy. I would tell you that in at least in the United States, if you look at our guidelines, the American Urologic Association, American Society of Clinical Oncology, Society of Urologic Oncology, AUA, all of them say you do not give metastatic disease just androgen deprivation therapy. You don't give it just a drug to lower the testosterone. You always give it in combination with something. This study was done looking at, as I say, Nubeqa versus placebo added to ADT. These were patients with metastatic castrate-sensitive prostate cancer. They stratified them by whether it was in organs such as lung or liver, since that would be expected to make them do worse. And they had to have a reasonable performance status. And they also looked at secondary endpoints such as overall survival, time to needing subsequent therapy, time to becoming castrate resistant, time to your PSA elevating, time to progression. So they looked at some other secondary things as well as safety for both of these arms. The arms were matched as far as balance between the patients who got the placebo and the patients who got the Nubeqa. Of note, and this is actually how it exists in the population. About 75% of the patients had de novo metastatic disease, meaning when they were diagnosed it had already spread. And about 25%, 22% had disease that originally was localized, but now it had spread. The majority had high volume disease, so they had a lot of cancer, and that was about 80% of them. A small number, about 10% of it was in a viscera, a lung or liver. And as far as prior local therapy, it would be a small number, 18%, the same number that would be in the group that now have metastatic disease. They would have had a previous therapy. Most of the patients have bone metastases. That's how the population is. 70–80% of men with prostate cancer that spread have it in their bone. Usually about 50% have it in their lymph nodes. So this is the progression-free survival, radiographic progression-free survival. The top arm is the patient who got the Nubeqa. The gray line is the patients who got the placebo. And the difference between those two curves represents the improvement. There was a 46% reduction in the risk of progressing or dying if you got the Nubeqa versus if you only got ADT alone. And if you looked at, these patients were followed on average for about 2 years at the time this study was analyzed. And this is the data that was brought to the FDA that got darolutamide approved. They also looked at some other endpoints. This was the overall survival in the two arms. And neither arm had been reached at the time of this analysis. But at the first statistical analysis, the survival analysis, a similar number of patients had died in each group. They then looked at the time to metastatic castrate resistant prostate cancer, which, as I said, is something that you want to avoid as long as possible because it significantly changes your treatment options as well as the quality of your life. And you can see these two curves are quite different, and you can see by the way, just so you understand how we do things in life, this slide deck came out on, I think, Wednesday, and I had clinic on Thursday, and in between patients I was trained on this slide deck. So there's the hazard ratio, which is why I want to go into what exactly the hazard ratio was. So 1 minus the hazard ratio is how much you improve something. So this is a hazard ratio of 0.4, so that's a 60% decrease in the risk of going on to your time to developing metastatic CRPC. If you got the Nubeqa, you can see those curves are quite different, showing a benefit in terms of delaying progression to castrate-resistant disease. This is another secondary endpoint. Some of our men live by their PSA. This is time to PSA progression, and you can again see that the patients who got the Nubeqa had a much longer time to PSA progression. So the difference between the orange line and the gray line, you can see it's a 46% decrease in the time, in the risk of time to progressing by PSA. We actually, in prostate cancer, we usually don't change treatment just based on a PSA going up. It certainly distresses everybody, but we usually wait until they have radiographic progression. That's sort of the standard in the treating of men with prostate cancer. As far as side effects, between the Nubeqa, which is the little orange box, and the placebo, which is the gray box, you can see that the percentage of patients with adverse reactions is very low. No substantial increase in adverse reactions in patients treated with Nubeqa versus ADT alone. You see this tiny increase in urinary tract infections between 8 and 12%. Many men with prostate cancer, because they have a large prostate or different, the urinary tract infections are quite common. But when we were talking earlier about our goals of therapy, one is to have a therapy that's well tolerated. And as you can see here, the side effect profile is similar between getting the Nubeqa and getting a placebo. This is some of the other adverse reactions. I mentioned earlier that you are concerned about maybe some cardiovascular risk factors. So you look at here at hypertension, see the percentage of patients with hypertension was basically the same. Cardiac arrhythmias, diabetes, fatigue. If you see almost all of these groups here, decreased weight, coronary artery disorders, bone fractures, you see that the difference between the patients who got the Nubeqa and the patients who got the placebo is essentially no difference. So if you look at tolerability in terms of permanent discontinue rate, you see that 9% of the patients on the placebo stopped their placebo and 6% on the Nubeqa stopped their Nubeqa. So I guess the placebo wasn't as well tolerated. And 96% were able to stay on the treatment without a dose reduction, and 85% of the patients did not need any sort of dose interruption. So very well tolerated. There is a potential embryo-fetal toxicity, and so those of us who do this for a living find a sort of comment about males with female partners need to be careful, since men who are on hormonal therapy pretty much all have erectile dysfunction. So pregnancy is not usually something that we see. So we'll talk about this case study. This is Mr. Whitaker. He presented in 2023. He had some urinary infrequency and he had low back pain. His PSA was 102. Anybody who has a PSA over 100 almost always has metastatic disease. So he was 102. His prostate biopsy showed a Gleason 9. Gleason scores are what determines aggressiveness of prostate cancer. His was a 9. 10 is the highest score you get. And he had bone metastases in his spine and pelvis. So he has de novo metastatic castrate-sensitive prostate cancer. He has a few other medical problems. He's got some hypertension, BPH, no prior cancer or surgeries, no prior heart attacks. Father had prostate cancer at 81. He had a brother with prostate cancer. His mother has a little dementia at 93. What do you want? 90. And then, so he lives in Charlotte. He's a non-smoker. So he's ready and interested in getting treated. And so he initially had a prostatectomy. So radical priming was performed. He got ADT. He started Nubeqa, and I'm trying to figure out. I'm just looking at this right now. So he gets monitored and he does reasonably well. We usually check the PSA and some chemistries. Darolutamide really doesn't affect, doesn't cause liver dysfunction, renal dysfunction, although you do have to modify it if you have severe renal dysfunction. You have to give them a lower dose. But we get PSAs and testosterone, making sure the androgen deprivation therapy is keeping their testosterone low. monitored him for other medical problems. And at the end of 12 months, his PSA, well, at the end of 6 months was less than 0.2. He has a little bit of fatigue, but otherwise, he's doing very well. So the goal of hormonal therapy, one of the things, you really want to get the PSA as low as possible. So there was a recent presentation last week at our big oncology meeting where we're saying that you want it less than 0.2. Now they say you want it less than 0.1. The lower the better. The lower the better, associated with the longest response and the longest life. So Aranode has, as I said, there are some safety issues, but as you saw in the adverse reactions, very similar between the arm that got the placebo and the arm that got the Nubeqa. So ARASENSE is the other trial, and so by the way, is anyone keeping track? When do I have to, how many more minutes do I have?
Go ahead.
I'm good?
Yeah, go ahead.
All right. I stopped wearing a watch. It's the most liberating thing I ever did. All right, so ARASENSE was the trial that got it initially approved for castrate-sensitive prostate cancer. Yes, ma'am.
So I have 2 questions. So have you done any study on Viagra? Because it's just like you said, and also, what is the route of administration of this Nubeqa?
Of the darolutamide?
Yes.
Darolutamide is a pill.
It's a pill.
It's 2 pills twice a day.
Okay.
And if somebody has severe renal dysfunction, you drop it to 1 pill twice a day. Yes, we have studied Viagra, and it doesn't work. So what the problem is when you lower your testosterone, your libido drops out. And in order for a drug like Viagra to work, you have to have blood flow into the penis. You've got to be interested. And if you're not interested, it doesn't work. So, yeah, we've studied it, it doesn't work. But other things are like Caberjet, which is an injection that will give a man an erection whether he wants to or not. I joked, this looks like a little group now. There's something called Caberjet. It's an injection so a man can have an erection. And the person who actually was involved in the first clinical trial stood up at a national meeting. This, of course, is before when it was allowed to be done something like he actually dropped his pants and demonstrated how it worked.
How is done?
He really did that at a meeting.
What state is it?
I mean, it's very surprising if you are willing to.
Yes. Georgia.
So, the PSA will be down less than 0.2. That's what you observed. 0.1. What about testosterone?
The testosterone, you want it to be castrate. What castrate? Castrate is defined as less than 50.
Yeah.
We really prefer as low as possible. So, depending upon your assay, it may be less than 3 or less than 7. But you want it definitely to be under 25.
What about the fatigue?
The fatigue, the darolutamide does not really cause a lot of fatigue. If you saw in the versus the placebo in those 2 arms, the major side effects. You do have side effects from ADT, drugs that lower your testosterone, but the addition of the darolutamide does not increase the fatigue level.
Okay.
Yes, ma'am.
I have a question. From what I'm hearing, the relationship between prostate health, relationship between treatment for prostate cancer has something to do with fertility?
No. So a man who has a lower testosterone should be able to produce sperm. As far as, but lowering your testosterone affects your interest in sex, which is different than your fertility. Better in the patients who got the triplet therapy than those who got the ADT plus docetaxel alone. So there was a 32% reduction in the risk of death over docetaxel and ADT alone. And I want to point out something because this is the question. Okay. You look at right here, this is basically 4 years. And that's the number they want to know. If I do this triplet therapy, what's the chance that I'm going to be alive? And you'd say If you could go out of 6 years, 5 years out here, you're going to see that more likely than not, you're going to be alive at 5 years if you did this triplet therapy. This is not pancreatic cancer, even in metastatic disease. At 4 years, 63% of the patients who were on the triplet therapy were alive. So that's the question I get asked the most. That actually is the question that makes them the most relieved, because most men, when they walk into my office and they've just been diagnosed with metastatic cancer, figure they're not going to be around in 6 months. That's not true. So if we also looked at time to disease progression, you can see that there's a huge difference between the patients who got the triplet therapy with Nubeqa versus those who just got ADT plus docetaxel chemotherapy. Again, there's a 64% risk reduction in progressing if you got the triplet therapy. Now, if you look at some exploratory analysis, these things, there's no statistics because they are subset analyses. But one of the things I mentioned earlier is how low do you want your PSA to be? And here they defined undetectable as less than 0.2. And as of the meeting I was at last week, they've decided that less than 0.1 is even better. But this is looking at what's the chance your PSA will be undetectable. So there's all sorts of studies that have been looked at, the sub-studies looking at how are you going to do if you get an undetectable PSA. So, and what is the driving this? So what actually appears to be driving this is at 6 months, 8 months, 12 months, any time. The orange lines is what percentage of people have an undetectable PSA that were on Nubeqa. And you can see that at any time it's like 67% up here of patients on the Nubeqa, whereas it was only 26% in those who got ADT plus docetaxel without the Nubeqa. So this is what's driving it, because the lower you get the PSA, the longer you live. And this is, as far as people being on it, they stayed on it for nearly 2.5 times longer compared to the patients who did not get the Nubeqa, and 41 months versus 16.7 months, because they were responding. They were not progressing. And I mentioned that it doesn't really add a lot of toxicity. The orange, these are adverse reactions that occurred in more than 10% or a greater than 2% increase over the placebo plus docetaxel arm. These are the two arms. So if you notice that the orange and the gray are very similar. We have constipation, rash, decreased appetite, some weight change, hypertension. You don't really see a difference as far as the Nubeqa adding toxicity. The main toxicity is in this trial is the toxicity from the chemotherapy. Those 6 cycles of chemotherapy. Those are what cause myelosuppression, fever, nausea. But the Nubeqa is not the culprit. And this is grade 3 or 4, you're more serious. You can see they're all way low down here in the 0.2, 0.3 range. You've got a little bit more hypertension. So as far as tolerability, we have 14% versus 11% of patients permanently discontinuing it. Greater than 90% of patients were able to be treated with the Nubeqa and the docetaxel. The vast majority of patients, the average number of patients basically got all 6 cycles of docetaxel. And 80% of men did not require any dose interruption. So usually the problem is pushed by the docetaxel. Once they get through the docetaxel, they're sort of home free as far as side effects. Adverse reactions, again, this is a large list of adverse reactions, but they're very similar in the ARASENS trial, just like in the ARANOTE trial, very similar between the two arms. The main toxicity being driven by the docetaxel chemotherapy and not by anything else. And of course, COVID being COVID, that's always this was done during COVID, so of course they saw some COVID, but it was equal in both arms. And by the way, I had every intention of getting my colonoscopy. So Nubeqa can affect other drugs, and other drugs can affect Nubeqa. One of the things, when you're talking about androgen receptor inhibitors, one of the things that comes up a lot has to do with anticoagulants. And is there a problem if you're on an anticoagulant? And if I go into, well, it will be another slide up here soon, but it does not interact with anticoagulants. You do not have to worry about your Eliquis, etc. And so that it's not a problem, as they say. The biggest thing you have to remember about darolutamide actually is that if you have significant renal dysfunction, you do have to dose reduce. And of course, you know, men, some of them do and some of them don't. So as far as dosing, it's dosed, Nubeqa is 600 milligrams twice a day. They're 300 milligram pills, about smaller than a dime. And you're either, now because it's approved in both settings, you can either, if a patient does not want chemotherapy or they're not fit for chemotherapy, they can get Nubeqa with ADT without chemotherapy. If they have high volume disease and they're fit for chemotherapy and they're willing to take chemotherapy, they recommend that you get the chemotherapy started within about 6 weeks of when you start the darolutamide. So usually I usually do this sort of in a graded fashion. You start your ADT and then your darolutamide, and then I have you come back about 3 weeks later, and I'll say, and then we'll keep talking about the chemotherapy, because actually, if you ever try to actually give them all this information at the same time, you overload people. Hardly anyone isn't overloaded when you try to tell them you're going to give them 3 different drugs and tell them all about it on their first meeting. So you have to sort of do this in a sort of a staged fashion. As I mentioned, you do need to lower a dose if someone has significant renal dysfunction. And you have them stay on it until they progress or they have unacceptable toxicity. There's a lot of ability to get help with coverage of the medication. If you have commercial insurance, usually there's a zero copay program. Medicare, for those who have Medicare, if you have Part D, you know, there's a $2,000 cap, which is still a lot of money per year for all of your specialty drugs. So if you are on more than one specialty drug, all of the drugs, it's $2,000. It ends up being, I think, $167 a month, and they let you pay it out over a year. There's also, for patients who, there's a 1-month free trial, so you can get started right away at no cost. And then there's some, depending on where you work, you can get a 30-day free sample program. And then, of course, there's always, for patients who are low income or don't have insurance, there's always a drug that can be provided at no cost. And you know, I don't know what the exact number out there is for darolutamide, but in general, at least in my patient population, about 40% of patients are getting free drug. And I'm at Georgetown, I'm not in the middle, you know, it's still, you know, so these are some of the drugs that potentially can be interactions. As I mentioned, it is not a problem with anticoagulants. There are some drugs that you have to think about. I always call it like the Zols, the Mysins, and the Veers. You may need to modify a dosage when you have patients on those drugs. You may want to try it. You're supposed to always stay away from grapefruit juice, but there are certain groups of drugs that there is an interaction with. At least in our hospital, we have a specialty pharmacy group team who very nicely for me, if I overlook something, will tell me if there's a drug-drug interaction. And of course, if you're using electronic medical records, it also automatically screens you for drug-drug interactions. But if I do overlook something, I guarantee you I will get a phone call. So this is the, as I mentioned, there is no issue with interactions with anticoagulants. So that's a really something that to think about when you have patients who, a lot of our patients are on anticoagulants. That is not an issue for patients to take Nubeqa if they're on an anticoagulant. You don't have to do any dose adjustments. It also has the NCCN Category 1 preferred option for triplet therapy, for double therapy. It has a Category 2A option, which means, which is a lower level of evidence but general consensus that this is an appropriate therapy. And that brings us to our summary. So we have now 2 indications in metastatic castrate-sensitive prostate cancer. It is the only FDA-approved drug that has approval both with and without docetaxel. The ARANODE trial, which has caused a significant delay in radiographic progression, so marked improvement in radiographic progression-free survival, and the ARASENS trial, which showed a significant improvement in overall survival as well as time to progression, radiographically, as well as PSA progression and time to metastatic castrate-resistant prostate cancer. So both of these, so this drug is available, as I say, with or without docetaxel. And with that, I can answer any more questions. Yes, ma'am.
I just want to be clarified from what you're saying. So, just want to be sure this is what I'm understanding. So the Nubeqa, you give the Nubeqa and the person still have to have chemotherapy. So what if the person does not have I'm thinking of overseas. I have an uncle right now. It's like this topic is for me tonight or this afternoon, that they just called me 2 days ago and said that he has prostate cancer, which is like, it's metastasized. They don't go to tests and all of this that we do, all these screening tests that we do here. So when you started teaching this, I'm like, okay, that was why I was asking about the route in the first place and if it's a PO. But then as you kept on talking and you're talking about chemotherapy. So my question is this, so will the Nubeqa not work without chemotherapy?
So you can give Nubeqa either with or without chemotherapy. If he is fit for chemotherapy and he has, well, even if he has low volume disease, but certainly if he has high volume disease and he's fit for chemotherapy and he wants the chemotherapy, that would be the recommendation, that he got the hormonal therapy plus the darolutamide plus the chemotherapy. I had a patient who was so mad at me because he's doing fine, he's in his 80s, and I said, I don't know that you're fit for the chemotherapy. He says, I'll be fine. I want to live, and I want to live as long as I will be fine. And he's only got 1 more cycle to go, and he's fine.
Well, for him, he wouldn't have an access to the chemotherapy. That's actually why I'm asking about the pill. So it might be easier for me to buy the pill and send it to him as opposed to chemotherapy, because he doesn't have any access to any chemotherapy at all.
We wouldn't give him hormonal therapy plus chemotherapy without the pills. You're either going to get a drug to lower your testosterone, let's say a shot of Lupron or an oral drug, and you're going to get the pills, the darolutamide, those are pills, so that's 2 things, that's doublet therapy. But if you really want to have the benefit that was seen in the ARASENS trial, the second trial, you have to add the chemotherapy. That's for high volume patients. That's going to be your best chance of having a longer life. There's a price you pay. Everybody doesn't agree to chemotherapy. It has toxicity. It increases your risk of infection, nausea. But if he hears about it and he's going to decide, or you're going to help him decide.
He does not have access to the chemotherapy.
He doesn't have access.
Access. That's the point.
Oh, I thought you said access. Okay,
exactly.
access.
He can't get. He doesn't have access. There's no chemotherapies available for him. So I'm just asking because I don't want to waste my money if the Nubeqa is not gonna work alone, and they really need the chemotherapy with that, because I know he doesn't have any access to chemotherapy right now.
That's a reason to not get chemotherapy. That's something he can't get. So he should just get 2 drugs. And I would say that in my clinic, I would say maybe of the men with metastatic prostate cancer, probably maybe 30% get triplet therapy, and maybe 70% get just 2 drugs, doublet therapy. Because of either not willing to take chemotherapy, not being fit for chemotherapy, or some other reason.
So what she's saying that since she cannot, because we come from third world countries,
yes,
we don't have a chemotherapy.
Right.
So with that 2 therapy, can it help him? That's the question.
Yes.
Okay.
Yes.
Okay. Thank you.
My question is,
so glad.
So the higher the PSA, the more likely the patient has prostate cancer.
Correct.
Then, during treatment, we monitor the PSA. Is that what it is?
Mm-hmm.
The levels of the PSA should be coming down then.
If the PSA goes down, your cancer is responding. So you don't have to do a bunch of radiographs. You don't have to just like do frequent bone scans. If the PSA is dropping and the patient is feeling better, you know that what you're doing is working.
Okay, how do you know if it is metastatic?
You know it's metastatic because usually initially, and it depends again at what you can get where you are. The standard assessment for metastatic disease is a bone scan and a CAT scan. The standard problem in the United States, though, a lot of people get something called a PSMA scan. There's a pushback right now from Medicare, even in the United States, to do PSMA scans. They are really pushing people to get a regular bone scan and a CAT scan. And if that shows something, there's no reason to do any other study. You don't have to, you already know it's metastatic on those scans. You can even, depending if you're talking about cost, you can, if you got an x-ray of someone, just a plain x-ray of their chest and their back, you're probably, if they have bone metastases, you can see sclerotic bone lesions just on a plain x-ray. And for what it's worth, as I said, everybody's different, which is a good thing, I guess. But I have had plenty of men who have said to me, I've had some men who said to me, look, my PSA is 1200. I've got bone lesions on my x-rays. You know I have prostate cancer. There's nothing else that causes a PSA of 1200 and bone lesions except metastatic prostate cancer. I don't want a biopsy. I don't want my prostate biopsy. I just want to be treated. And they're absolutely right. There's a 100% chance that person has metastatic prostate cancer, and you actually don't need to do the biopsy to prove that. Yes, ma'am.
Can you switch the second generation of individuals?
Say it again.
Can you switch like Rebecca and either to Cytiga, like if they had one, can you switch them? If they're not responding to one, can you?
Okay. So if you're not responding, let's say you got Rebecca and ADT and you're not responding to it, that's unusual, by the way. But let's say you were not responding to it, going to abiraterone as a second line therapy, that's a different mechanism. Has about it's got a relatively low response rate, it's like 18%. So usually, but you can do it and sometimes it works. There's all sorts of tricks about all these drugs. When you talk about cost and access, like abiraterone, you can take one pill instead of 4 pills with a low-fat diet, and then you can get it for good RX down to about $150. So there's all sorts of things to do when you're trying to be creative.
So the cardiac effect is like the arrhythmias. Some people with the ischemic heart disease can end up with having arrhythmias. Even though you've treated the hypertension and then you put them on beta blockers for the arrhythmias, can you go ahead and give them Rebecca?
You should be Cardiac, I don't think there's a problem with like toprolol, things like that.
No, I'm just saying that if they have arrhythmias, as long as you are treating the arrhythmias and the hypertension, it should be okay to continue.
Yes, yes. In fact, that was one of the slides where they looked at cardiac arrhythmias. At least as far as the darolutamide versus the placebo, there was no difference in the incidence of cardiac arrhythmias. She wants me to end. She gave me my 5 minutes. Stop.
Would like to thank Dr. Nancy. Our company also sponsored the launch, so let's give her another round. Thank you so much.
Permit me to introduce our next and final speaker for today. Ladies, one house, please. I will be introducing Dr. Tamara Hudson. Dr. Hudson is an associate professor with tenure at Howard University in the College of Medicine, Department of Pharmacology. He also has an appointment in the Howard University Cancer Center, an adjunct associate professor appointment at Johns Hopkins University School of Medicine. He received a Bachelor of Science in Biology at Iowa State University, and also a master's degree and PhD from Ohio State University. His research focuses on biomarker-based approaches that allows for the development of chemopreventive or clinical treatment strategies. Dr. Hudson has received extensive training that has advanced his knowledge about the importance of targeting biomarkers through prevention and therapeutic strategies. He has mentored many students from different educational sectors in and out of the university, including medical students to graduate pharmacy fellows, microbiology graduate students, undergraduate student volunteers from the biology department, and graduate students in the Department of Chemistry, as well as high school students from STEM programs. Ladies and gentlemen, please welcome Dr. Hudson.
Good afternoon, everyone. Yeah, it's the last one. They say the first shall be last, last shall be first. I want to thank the African Women's Cancer Awareness Association actually for inviting me to actually come speak to you. I know that they had originally got in touch with our director of screening, Clinton Burns, outside, and he couldn't be here today, so I'm sort of standing in his stead. And so I appreciate the opportunity just to speak to you on today. I'm not going to speak to you about treatment, but I do want to actually, I want to thank Dr. Dawson for actually providing a great deal of information on treatment options for men who end up developing metastatic prostate cancer. And so this particular presentation on today, after her, subsequent to her, gives me an opportunity to elevate the discussion about caregiving. So that becomes critical. So what do you do? We sort of talk about that platform in silo, but I'm going to try to convince you today it shouldn't be a silo. It should be a presentation of collaboration between health professional and the caregiver, as well as the patient themselves. And so hopefully I'll be able to do that. I have no financial disclosures, and so we're going to get into it on today. So once again, thank you for the opportunity to present this lecture. So I'm going to try to talk about the challenges faced by caregivers of prostate cancer patients. And so in my research and being in the clinic and working with patients and actually also working with caregivers and actually working with caregivers in regards to recruiting patients into my studies. I found that there was a sort of a loss in translation in terms of communication between ourselves and the caregiver. And so that actually put barriers between maybe participation and also the understanding around treatment options for their patients, as well as quality of life as well. So hopefully today, in terms of elevating this discussion, we can maybe not come to a consensus, but really start to think about different models that can actually be incorporated within the realm of health professional. Specifically, I'm talking about cancer patients as it relates to caregiving. And so how does that model look for you and you or whoever is actually providing the caregiving? So my objectives on today is to really highlight the critical challenges in caregiving, address how the healthcare system rarely addresses the needs of caregiving, and then address the impact of health professionals on caregiving and provide information on how these supportive systems are very critical to the care of the cancer patient themselves. And so, and since I'm talking about prostate cancer, Dr. Dawson actually alluded to this, is that as you can see how common is prostate cancer. You see that it's in regards to those who are diagnosed in prostate cancer, it's the second most common cancer disease as it relates to breast cancer. And as you see here, prostate cancer represents approximately 15.4% of all new cases in the United States. If you also look worldwide, prostate cancer is also the second commonest disease related to the cancers, and I think approximately 1.3 million end up dying from the disease itself. So with that said, when you begin to look at the SEER data, you find that, as Dr. Dawson alluded to, in that although there was a decrease around, I guess, let me see if I can highlight my laser pointer. As you can see, there was a decrease over a period of time to about 2012. The incidence begins to decrease. What I want to highlight before you today, this represents non-Hispanic, blacks, or African Americans. You continue to see the disproportionality between those who are African American or black and other ethnic groups. In addition to the incidence of the disease, you see the mortality. And so although the mortality of the disease is decreasing over a period of time, you still see this disproportionality between African Americans and other ethnic groups. And so at Howard University, we have what we call a MANTATE 10 prostate cancer screening program. And within that screening program, we are obviously looking at early detections, considering the pattern of disease as it relates to incidence, as well as the mortality of disease as it relates to the African American or black population among men. And so we screen men. You do not have to have insurance, actually. We screen men on a quarterly basis, actually. And within that screening, we do actually perform PSA as well as digital rectal exams as well. And so that allows us the option of not only having the option of having your PSA, but also the ability for them to measure any type of nodules that would surround the gland itself. And so the question becomes, okay, you have the incidence of the disease going up, you have the mortality, although it's decreasing, you still have the disproportionality of men who are dying from the disease. And so with the development of the disease and with those that are actually also the disproportionality within the black community, the question becomes, there will be an unmet need in regards to caregiving. What does that look like in the United States? And also within the framework of the environment now in regards to reduction in funding, what does that look like in regards to caregiving? And so when you begin to look deeply at caregiving, you see the status in that the number of family caregivers in the United States are actually increasing. Right? They're actually 18.2 million in 2011 to 24.1 million in 2022, reflecting a significant rise in caregiver responsibilities. And so that means that models going to have to be in place as well as research. There are different demographic shifts, and so the average age of caregivers has been rising with notable increases in caregiving around the age of 65 and older. And so in 2022, you see that 36.3% of caregivers were under the age of 55 years and older, and 62% of those were actually females. And then with the demographic shifts, you see caregiving recipient relationships, and hopefully we'll have an opportunity to discuss this, and that most caregivers are adult children of individuals they care for, highlighting the familiar nature of caregiving. So that lets me know that there is this important relationship of caregiving, the role of it in cancer care continuum, whether it be through diagnosis, whether it be through treatment, whether it be through survivorship, or whether it be through end-of-life care. Oftentimes when we're thinking about caregiving, we're often thinking about sort of end-of-life care, but there is a continuum as it relates to caregiving, and so that means that there are contributions that are included in this continuum as it relates to emotional and psychological support. Practical and medical assistance is needed, advocacy and decision-making, as well as continuity of care and improved patient outcomes. And so when you look at emotional and psychological support, that means that you're looking at the ability to provide some stability in terms of helping and managing fear around the complexities of someone actually developing cancer. What does that mean for me? What does that mean for my family? How are we going to actually navigate the terrain of this diagnosis? And so the practical medical assistance and whether or not, can I attend these appointments? Can I be assisted in medical tasks? What does that advocacy looks like in terms of a supporter as well as informed decision making, and then what does the continuity of care looks like as well. So who are caregivers? They're family members, they're spouses, they're partners, they're friends. They're often unpaid, untrained. Oftentimes we think we are trained, just because we're in the field, we think we are trained enough in caregiving for someone. You will quickly find out how much you are not trained for caregiving. And then emotionally and physically close to the patients, and usually you are emotionally physically close to the patient because you live or you're near that patient. And so I think there are different definitions of who becomes a caregiver. There are emotional and psychological challenges as well, from anxiety, depression, and fear of loss for the caregiver themselves, right? So you're taking care of this patient and trying to figure out whether or not this patient has a good quality of life. What happens when they're at the end of life? What does that look like for the caregiver? Emotionally exhausting for the caregiver in terms of burnout. There's guilt, there's helplessness in terms of caregiving as well. Okay. And the thing about caregiving, although I'm talking about it in relationship to cancer, this is in regards to any morbidity, any disease that we can think of today. Caregiving becomes an important factor and element that plays an important role in all our lives when we think about caregiving. But we often don't think about it because we think about it in silo. We don't think about it in terms of a contributory action between us, the health professional, and the patient themselves. The physical and health impacts, when you're talking about sleep disruption and fatigue, neglect of personal health, the increased risk of stress-related illnesses. And so you can just often think about the caregiver, although they're taking care of someone, their loved one who has a disease, you can end up occurring diseases yourself as regards to stress. So now you're taking care of this person, then you incur any type of morbidity to disease as well, whether it be from diabetes, hypertension, and any other stress-related disease can actually develop as a result of the stress-related incidents in regards to caregiving. Now, the other consideration and challenge is financial and occupational strain, right? So loss of income, employment adjustments, out-of-pocket costs, where are they going to come from? And usually in caregiving, it's limited access to financial assistance program. We're going to see that today. We're seeing it right now, right? So a lot of governmental programs have been cut. A great deal of them. Of those programs, the respite programs and the caregiving programs, they come out of the Medicare and Medicaid programs. And so here you see, if you reduce those programs, especially for populations who can less afford someone to take care of a family member, or they're in situations where they need additional assistance, this is where that financial and occupational strain actually occur. And the question becomes, what happens within the scope of while you're taking care of this individual, at the same time you have a financial strain on yourself and trying to take care of the individual. So now you have a situation where you have maybe loss of income. You may lose your job as a result of caregiving for this individual because they may need around-the-clock care. So what happens within that spectrum when you do not have the assistance that would be needed for caregiving? And then the social and relational strain, the isolation from friends and family. So you have limited time and energy for social interactions and feeling of loneliness and being forgotten. The strain of family dynamics, who are going to take care, right? So if you have, even if you have a large family, who decides to take care of the one that's actually in a position where they need round-the-clock care? Who's going to take on that responsibility? And so this becomes really critical in trying to ascertain a caregiving role. And then you have challenges in terms of changing relationships with patients. You end up, so if you are a spouse and you end up taking care of your mate, that change in dynamics because, I mean, although they're your spouse, you become their caregiver, right? And so that could change the relationship between you and your mate and your spouse when there is a situation where you have to take care of someone. Also, the emotional distance or the role reversal can create tension and grief between you and the patient, right? So there could be a strain between you and the patient themselves. The lack of support and resources, the limited, which indicates limited caregiving for specific support groups. There are few structures that are out there in terms of the spaces of emotional support and shared experiences, the gaps in medical guidance and communication, the insufficient respite care and educational tools that actually surround what is needed and what is available for caregiving. The lack of access to training, the lack of access to tools that can actually help you manage emotionally, the needs for not only yourself, but also for the patient as well. And then there are cultural and gender considerations. And so we often see this in the clinic, is, you know, when for patients, if English is not their standard language, and trying to actually communicate to them the needs for the patient. And so male caregivers is a stigma these days, right? So the idea is that when we're talking about caregivers, the frame of thought is going directly to a woman, a female, right? But to be honest with you, they should not be the only ones taking care of someone that are in need, right? And so that's always, not always, so that's been sort of the model that we look at when we're talking about caregiving. So this, you know, and so the stigma around a male taking care of someone that's in need in their family is weakness, which in all actuality, it's not weakness, it's actually a support system that should be needed. Everyone should be highly invested in helping to take care of their loved ones. And so men are often faced with sort of this societal expectation of being strong, right? And avoiding expressing their emotions. And so this often leads to less consideration of taking care of a loved one. And the cultural expectations around caregiving. So in some cultures, caregiving is viewed as a family duty, right? And it's not a shared or professional role, but it's a family duty. And the stigma around asking for outside help can actually be considered a weakness. But I would employ today, and I would suggest that the model system should be that you should ask for help outside the framework of your immediate family. And then cultural beliefs may influence perceptions of illness, aging, and end-of-life care as well. So there are very few articles related to caregiving. And I love this article by who did research on the challenges faced with family caregiving of prostate cancer patients in Cape Coast, Ghana. He did this descriptive immunological study where he took families who were actually taking care of patients who had prostate cancer. He assessed their needs. He looked at it from the standpoint of education and training, resources, caregiving, nurse relationships. And so he had the main things, and then he had the sub-things. The sub-things were the outcomes, actually, from the main things. And what he found was that there was a lack of preparedness towards the caregiving role. He saw that there was a lack of knowledge about the conditions that they were facing. He also found the financial constraints, just what we were talking about, the lack of accommodations of facilities for caregiving, and he also found poor communications and poor staff attitude towards the caregiver. So this highlights the disparity within caregiving itself, the lack of communication between the caregiver and the health professional and the patients themselves, which actually leads to ineffective care for these patients. And then stress comes in because now the caregiver does not feel as though they have the information that would be needed to actually take care of this patient. So we have some potential models that are out there based upon some of the information or the limited information that is there. But the question becomes, are we going to actually sit around the table and start to develop some of these model systems that would be needed? Because what I'm finding in the clinic is that among the health professionals, like, well, that's the caregiver's responsibility, and not so much a partnership between the health professional, the caregiver, and the patient. So, I'm employing or suggesting that it's a model system where all should be participating in actually extending quality of life to the patient themselves. So, with that said, there are coping strategies and support systems, whether it be through counseling and mental health services. And so this is where health professionals come into play, where you actually need to communicate whether or not the caregiver is under constraints and what are the needs for that caregiver within that space. Whether or not they need counseling and mental health services themselves, in addition to the patient who has just been either diagnosed or are at the end of life. Is there respite care and support groups that are there? Caregivers often receive little instruction on complex care tasks. There's, like I said, poor communication between healthcare providers and caregivers. And education and training for caregivers are very limited within this space. So, and then there's a lack of access of training or tools managed in regards to the medical and emotional needs for the caregiver themselves. So what does that create? That creates gaps in the healthcare system. And so caregiver needs are often overlooked, where there's a lack of recognition. So caregivers are often treated as visitors, not essential members of the care team. So it's really, and I found that, so especially if there's a language barrier. And so their contributions to patient care are undervalued and under-supported. There's limited access to resources, so few formal programs exist to actually help to train or support caregivers. And then minimal inclusion in care planning. So we think about financial planning and all these other plans, but we do not think about caregiver planning, actually, for those who are taking care of loved ones. The ability to handle emotional and physical strain is often ignored by caregivers. So you have high rates of caregiver burnout, you have anxiety, you have depression that have been well documented by caregivers. And then there are financial burdens that are always under-addressed because caregivers may lose income, personal savings, or may face out-of-pocket costs. And so, what is the role of a health professional in supporting caregivers? I would say that they are critical partners in care, right? They are critical partners, the health professionals. They serve as a bridge between patients, caregivers, and the healthcare system. So that bridge is effective, right? So it helps the caregiver to navigate the healthcare system when they have proper communication between themselves and the health professional. So I'm talking about doctors, nurses, physician assistants, all of those, or the team themselves, whatever that healthcare professional team, what does that look like? They should assist with the needs of the patient and helping the caregiver actually navigate the system. Effective communication really matters, so that you need clear, empathetic communication helps caregivers understand treatment plans and expectations. Education and empowerment is important, so training caregivers in basic medical tasks, and we often don't do that. As indicated, we look at caregivers in silo and not as a team. So helping them understand wound care, medication management, and it improves the outcome and it lessens adverse events from actually giving someone medication. Okay. Recognition and inclusion. When caregivers are treated as part of a team, it validates their role, it improves collaboration. Ignoring caregivers' perspectives may lead to burnout and gaps in patient care. And there needs to be systemic change. Healthcare systems should implement caregiving inclusive policies, such as regular caregiving assessments, training programs, and support systems are all needed. So with that said, at Howard University in a Man's Take 10 program, we do something unique, and I would say it's unique to our program, because in addition to providing screening, we also provide a what we call a peer-to-peer support group. So men who have been diagnosed, and then also men who have not been diagnosed, have the ability to participate in our peer-to-peer support group. Their caregiver also have the ability to participate in our peer-to-peer support group. We have a monthly, thank God for advancement, amen. I mean, thank God for advancement, because in Zoom and the ability to navigate them actually coming to the facility, and there was a time when we did it in-house. As you can see, we initially did it in-house, and when we switched to virtual, our numbers increased. So, and not only did the numbers increase, that brought in the caregiver, because the caregiver now can actually be in the same space, does not have to travel, that lessens the burden. And so they feel supported within this system. So the critical role of supportive system in cancer care, what is that? What is that role? It should be holistic in terms of the support which enhances patients' outcomes, right? So the emotional, social, and logistical support reduces stress, improves quality of life for both patients and for the caregiver. Caregivers as core team members becomes essential. Patients rely on caregivers for transportation, medication management, and I think that medication management becomes really important, right? Because if they can understand medication management, you can reduce the burden of being either overly medicated or underly medicated, right? And so there are adverse events that happens, adverse drug events that happen as a result of somebody being mismanaged in terms of their medication. Interdisciplinary collaboration, so coordinated efforts among doctors, nurses, and social workers. Emotional resilience through connections, so communities, peer-to-peer support groups are, spiritual care support groups as well, you know, at your churches, participating in social activities and support networks, actually help buffer the psychological toll of diagnosis and treatment and survivorship. And then without this support, I think gaps began to emerge because of the lack of caregiver support. It often leads to a higher rate of hospitalizations, poor treatment outcomes, burnout, and then patients may experience delays in care, unmanaged symptoms, and emotional distress. And so my last slide is just a model that I'm thinking about myself. Is not extravagant, but it's inclusive. What I say is inclusive because it hones in on the caregiver and then the health professional in relationship to the patient themselves. And so the caregiver, the health professional, and the cancer patient. I didn't put a specific health professional because you're looking at, like, as I indicated, a core team of individuals. What does that core team looks like can be different for many people. You may be in a rural area, so your core team may be different if you're in a city, or you may be in a different country where they may not have all the particular services in relationship to the study in Ghana where they didn't really have a great deal of screening options in their community. So what did that do? That increased the burden rate on the caregiver because they weren't being screened, they were being diagnosed at a much later stage of the disease, which actually increased the burden on the caregiver. So what does that core team looks like is different for each individual as it relates to wherever you are within your state or country or position. So in summary, I would suggest and indicate that there needs to be an expansion of caregiver-focused research because when I started researching, it's not a lot out there in regards to caregiving because, as I indicated, they just look at it as not a team-oriented approach. They look at it in silo. They don't have a great deal of models out there, so there should be investment in studies that examines the burden of caregiving, the mental health status and support needs. There needs to be evidence-based interventions for caregivers tailored to diverse caregiving communities and populations. You need to be able to integrate caregiving support systems into cancer patients' plans. So that means including caregivers in consultations and decision-making, provide training, counseling, and routine caregiving wellness assessments. And then we want to be able to advocate for policy and systemic change. Push for healthcare policies that fund respite care. As I said, even in the state of Maryland, those caregiving needs are actually being reduced. The programs that was originally in place are actually being reduced as a result of budgetary factors. And then, so there needs to be caregiver education and mental health status. encourage workplace protections and financial support for unpaid caregivers. Oftentimes we think if something happens that we will be great caregivers. You will not know whether or not you're a great caregiver until it falls into your lap. And you think you have the resources, you think you have all the knowledge base about caregiving. But to be honest with you, we do not have the knowledge base because we have not done a good job of actually researching, training, and setting guidelines around caregiving. I want to thank you for, let me go back. So are there any questions? And I want to thank, once again, the African Women's Care Awareness Association for allowing me this opportunity to speak to you about caregiving, the importance of caregiving, and the role it plays in.
Thank you for this presentation on the burden of chronic health problems on the caregiver. So because we've seen instances where the caregiver even dies before the people they take care of.
Yeah, right.
I've seen a couple of instances, and I have a friend now whose spouse is sick. She's mentally not stable because of what she's going through. So all chronic diseases, whether you know it or not, need caregiver on the side. And what I'm seeing, the system is now recognizing that the caregiver is important in the care of the patient. So it's being ignored. So I don't know where you work, who you work with. What are the plans for them to include the caregiver in the care team?
You know, for me, I'm within the scope. I'm in the medical field, obviously, and so I'm trying to do my small part by doing the research and looking at ways in which we can create models that can actually assist with creating space for good quality of care, not only for the caregiver, but for the patient. So we often look at patient quality of care. But if you really think about it, if you increase the quality of care for the caregiver, that also extends to the quality of care for the patient themselves as well. Because when the caregiver is in a good space, mentally, emotionally, have full support, that actually leads to a better way in which that caregiver will manage the care of the patient that they're taking care of. And so at Howard University, you know, we're trying our best to create a model system around support, you know, as it relates to, you know, caregiving. Because I'm in prostate cancer, I work with patients and, you know, in prostate cancer. But myself, I am a caregiver, right? So I'm a caregiver of a son who has neurological conditions, genetic disorder. So he's going to always be with me in a sense, right? But, right, so with myself and my wife. But at the same time, I'm not going to always be around. So what does that caregiving aspect look like? And the reason why I started looking at this, because I looked at my own situation, but also the situation of patients that were coming into the clinic. They were coming in with their caregiver, and you could tell that the caregiver was emotionally drained. So the question became, what could we do for the caregiver? What support systems could we put in place that can assist to reduce that burden? And so this is where I sort of came up with sort of the presentation around creating spaces where, okay, if you want to shift policies, you got to do research. Yes. There's not a lot of research that is being done. Now, within the environment that we have now, it may be a little difficult, but I think still it'll be quite important for us to push for doing research within this space. Because to be honest with you, a great deal of burden falls within Black and brown populations as it relates to caregiving.
Yes.
So
Sorry, well, it could be true, but I work in the mainly Caucasian community. It's the same over the board. You have people with children, and these ladies end up in the nursing home. No matter how perfect it is, you know, they have their own living facilities and everything like that. But they don't have anybody that they can actually relate with. They have a lot of, you know, the nursing facilities bring them to clinic and do all that for them. But they still miss that I wish, you know? And so it's something that we really need to look into, like giving insurance to people. They should do the same thing for caregiver. Once you have a caregiver, there is a program they have now. Caregiver become the sole and they get paid for it.
Yes,
So
family.
and that's what you do. You can do something by the side, but the government will pay you for the amount of time that you spend with your loved ones, being their primary caregiver. And I think they should make this more open to people, you know. And it's not only your level of income. I mean, anybody can have their parents. Say, for instance, if I decide to look after my parents and leave my job, you can't just grade me on where I was and say, for benefits, it has to be $2,000 a week or a month. So you have to actually grade it like they do in Europe, depending on where you are, then they pay you for looking after, because that person becomes a burden on the state.
That is true. So, like you said, with the programs that they have now, they're limited in scope, right? They're limited in scope, and the issue in terms of the program itself is income based, right? So you're looking, right? It's looking at, and when it's income based, you're actually missing out on the care or the needs of the patient, because even though you're receiving a certain amount of money from the government, that money actually can end up being taken, you end up taking that money and using it for the care of the patient oftentimes. So it's, you know, you're really not, as a caregiver, you're not really benefiting that much. Because if you take it, to be honest with you, if you take once you receive it and the patient themselves are not receiving a great deal of finances, oftentimes you have to supplement the care and the needs of the patient. Yeah. So that's the problem with some of the present day programs we have.
So my question I'm asking, you know, since you're part of the program in your hospital, would it be great, because I think what caregivers do really need, caregivers themselves do need, is respite.
Yeah.
Respite care. They couldn't have, you know, I have my own child, my own challenges. They do need, the government pays you 10,000 a week. It's not enough, because when it gets down, it's so time consuming.
It is.
It's draining. It's draining. So that providers themselves in the home, they need their own time away from that patient.
And that is true. But that's why you're saying something critical. But the way in which the government look at it is that respite care is a luxury.
It's unfortunate. So what they
right? Respite care is a luxury. It's not instituted in such a way where it becomes a collaborative, effective tool for the quality of life, not only for the patient, but for the caregiver.
Yeah, so for respite, for billing purposes, there has to be a code for it, for the providers to actually bill. Yes. Yeah, and there has to be some documentation that the respite itself will benefit the patient and not the family.
Yeah.
So it's really dicey. We know in the long run the patient will benefit, but directly, a provider cannot bill for respite for family.
That is true. That's
documentation has to show
that they should really look into just a time mapped out for caregivers. I mean, yes, the patient gets the care all the time, but the drainage, the time they need, just the caregivers themselves.
They do, but oftentimes the caregiver doesn't even know about the program or how to even approach their health professional about the care. Because to be honest with you, what can be done is the health professional
can code it in such a way where it becomes beneficial. But if you don't ask for it, because oftentimes the caregiver, they don't think they can ask for the respite care. They don't think that the insurance will be able to provide.
And it can go into mental health.
Yes.
For the patient.
Yes.
And for the family. What insurance can cover.
Right.
Mental health.
But that's what I'm saying. When you're thinking about different models that can be introduced to actually help with caregiving. So the health professional becomes part of the team where you sort of sit down and assess the needs, not only for the caregiver, but for, not only for the patient, but for the caregiver as well. Yeah.
Thank you so much.
My question is, in light of the fact that this is a growing problem and we have a growing older population, and therefore the need for a caretaker increases, do you see any efforts to provide like financial assistance to caregivers? Is there any national movement or interest, such as you see, when it's like child care and that kind of stuff? So you haven't seen anything?
No, only state and local. Like you see certain groups, or you see it like within AARP. They have different programs, but it's not explicit, right? Because it's literally asking for respite care. That's what I say. It's like a luxury and not something that someone really needs. And so there's not a groundswell, especially within this environment, to ask for additional funding to pay a caregiver.
Another smart way to go about it is use your FMLE, because that's what you qualify. Of course, we do that. Yeah, with pay. I have approved it for some of mine. What I did. Yeah, so I've had a staff travel overseas to care for a sick
But
parent.
that's limited too sometimes, right? Because
it is limited too.
You get that space. Yeah, you only get that limited time. And just think about it. Okay, what if the patient needs around the clock care?
Right.
So now you're right. So you're only limited to that.
But at least you can get something.
You get something. But that's what I'm saying. So now you're sporadic in terms of the care, right? For the patient, for the family.
But the FMLA can also become without pay. Initially
you'll be covered. If it's extended, then you have to be without pay.
Then you don't get paid.
Right.
And then if the people at your place of work are looking at you,
Right.
you might lose that job.
But that's what I'm saying. The financial burden.
Right. But what this is telling us is there is need for us to advocate as healthcare providers and also as individuals, as family members, because you never know. It could be our loved ones tomorrow.
Yes, right.
So we are going to be going to Annapolis to knock on doors. This is the policy that needs to be passed. Definitely, it's a bill that needs to be passed, right?
It does.
We need to look out for us, especially the aging population. You've worked so hard. When it's time for you to get the help that you need, you want to get that help, right?
So they were pushing it. I think Bernie Sanders was pushing it at one point in time when he was talking about national health care. Because within that system, he was pushing for certain provisions that would cover like respite care, because we were talking about aging populations. But because you couldn't get that, nationalized, right? Now you have a system that is. What do you call it? What do you call the system? So, I don't know. My hope is that we can get to a place after 3 years to sort of readdress.
And definitely realistic. I like the word after 3.
To readdress some of the needs. Hopefully, because to be honest with you, I think we're going to have a setback in research right now. And I think because if those cuts do pass, that means you're cutting programs overall, right? And those programs, like I said, Medicare, Medicaid, they were really major in pushing some of the initiatives for like respite care and things of that nature.
We'll hold them down. Thank you. So.
that he's the only man on the panel. He needs another round of applause. So everything checked for him. So Dr. Hudson, we really appreciate your time. And we thank you for this wonderful education out there. So thank you very much, and we hope you can come back and be with us for such an important education out there for the community.
Amen.
Thank you so much. And thank you everyone for being here. Next time, we hope we don't have so much going on. Bring people with you. This is very important for our community. Thank you to all our sponsors, to the pharmaceutical rep. We appreciate you, and everybody drive home safely. Thank you, thank you, thank you.
Okay, wait. To get out, all you have to do is push the little buttons and they'll open up the gate. Just tell them you're with the conference.